Okay, good evening, everybody, and welcome to this very interesting webinar on conservative management of fractures. And for further proceedings, I'll hand it over to Dr. Chang.
Yeah, thank you, Ashok, for this wonderful platform, and welcome all viewers and faculty members. We are having a webinar today on conservative management of fractures, and most of the patients in our outdoor clinic and in our day-to-day practice, we manage more conservative than operative. And it would be really interesting to listen to all the faculty members on conservative management of fractures. And they will be giving us outlines when the conservative works better and when the case goes for an operative discussion. We also have a very interesting discussion on hand splints. So we have with us Dr. Jawahar Jetwa, Dr. Asim Negi, Dr. Samrat Tauri, Dr. Vivek Garge, Dr. Gade Gune is there, Dr. Vijayanand Lokhande, Dr. Yogesh Salfare, myself, Dr. R.M. Chandak, and Dr. Harjot will be moderating this session. Dr. Tanna sir would be joining shortly, and Dr. Mukhi would be joining shortly. So at the beginning, we start our presentations and a lecture from Dr. Samrat. Samrat, can you share your screen? So it would be really interesting. It would be interactive, and we invite all the faculty members to interact and give their valuable suggestions. Most welcome. Samrat, your screen we can see. Please proceed.
Very good evening. And I start with this case, fracture forearm managed conservatively and cast in supination given. And this is what I did. And what I want to highlight is that however we do nicely, there is some prominence here, and we have to actually go back and trim this edges here so that we get a good flexion at the metacarpophalangeal joint. So what I'm going to present today is nothing new, but it's just highlighting the fact that we have to take some extra care while we cast, brace or splint, and that's it. So I try to put up some splints for conservative management, and I thank everyone. And fortunately, I got this photo where everyone in the faculty, in the organization, is seen. So prescription of the hand split, when we send this to an orthotist or a hand therapist, there should be a diagnosis. There should be a purpose, whether it's for for the rest or for some injury or for conservative management or a post-op rehab. Material what we want to use, static or dynamic, and joints which have to be mobilized and which do not have to be mobilized. And we have seen at times that when we have not given a proper instruction, so we need to also write down duration, when to use and when not to use. Like in Kapner splint, we see it's a dynamic splint. It is spring loaded, so we can't give it at night. So we have to write about that also. So this is not about, but this is also very important. Limb elevation has to be very safe way. It has to have some wrist in extension. There should be no constriction. Here the elbow is well supported. And so this is also a splint, and we see this this doesn't work. This is wrong. I mean, if the patient really wants something like this, it has to be adjusted so that the whole this area should come here. And this is what when I don't give a splint, patient makes his own way of sling, and this works well. A few anatomical considerations. We know that the joint here, it is a distal palmar crease. Here it is the proximal palmar crease where actually the metacarpophalangeal joint properly come. That is my hand, and we see that this is the crease. So the cast or the splint, there are so many splints in the market which don't work well. They go up to here, so that has to be taken care of. This is James' position, and we know about this. So just a word about this. For acute injuries, this moldable splint or a dorsal or volar slab, which actually we have in our store, that can be used before we go for a proper splintage or proper treatment, whatever we want to do. and otherwise we can use this rest splint for acute injuries or immobilization. Coming to the management in fractures, where we are going to do a conservative management, especially in proximal phalanx fractures, if we get a very good reduction and there is no rotation, I use a dorsal slab, and that is for about 8 to 10 days, where we start mobilizing. I rarely start mobilize on the day one if I'm managing it conservatively without any fixation. But once the fracture ends are sticky and there is less pain, we can start managing mobilizing. So this already after the dorsal slab for about 8 to 10 days, body strapping was done. Patient was again put on a dorsal slab, and the ROM was started, which was ultimately the slab was discontinued after 4 weeks. So there are some pitfalls. That's very interesting. So this patient had a flexor tendon injury. It was repaired and he had open dislocation of the PIP joint. So an extension block wire was put here. So and we can see something happened. Actually, I've given a volar slab also here. So the patient had a jerky movement, or there was a decrease in the edema, and there was a huge my advantage that I took this extra for this and I revised this. So loosening leading to MCP extension and the IP flexion. This is something which can happen if a dorsal slab is not very well put. A lot of padding and a lot of nice fitting at the first web is the key to proper success in this. Also, if this metacarpophalangeal joint is kept exactly at 90 degree as has been described, I found maceration in the palmar crease. And I would prefer a 70-degree flexion at the metacarpophalangeal joint rather than 90-degree. A lot of gauze pieces has to be put. The other thing is that if the splint for whatever conservative management is going to be up to here from the fingertip, I prefer to put gauze pieces like this instead of just putting pieces, gauze pieces in the web space. A short video. I know that this is very basic, and we use a paper, this plastic POP paper for that. And what I want to stress here is that once this particular slab has been put, one has to have patience and just hold it till it gets completely set. That 1 minute or 2 minutes spent makes a huge difference in the strength of it. Also, as you can see, I have put ridges on the sides. There are other ways where the ridge is put on in the center. It definitely increases the strength. And as we can see, the patient, this is this was a distal radius, and this is a bit dramatic thing, but so this slab, as we have all experienced, this just stays well for 3 weeks, 4 weeks. You can use it. So I incorporated this particular video just to say that many times when we I'm sorry, I'm not able to proceed. So many times when we advise for a dorsal or a volar slab for any management, instead of prescribing it, if we make it by this POP, it is very moldable, it is customized, and it actually stays well for 3 to 4 weeks, whatever time we want to use it. So no need for a proper thermoplastic splint. This can very well stay for that time. Fractures, either after when we wean off from a slab, or when we think that it is very well suitable for just a body strap, can be used. And especially for children who have got small facial injuries, body strapping helps well for 3 to maybe 3.5 weeks. For the finger, I use it only when there is a tough fracture, because to protect it. So tough fracture in the distal phalanx, I use a finger cord splint, or cases where there is an undisplaced middle phalanx fracture or a distal phalanx fracture, where I want to give it a support from both the sides, dorsal and volar side. Otherwise, the most important disadvantage of cord splint is that it immobilizes the PIP joint, and if the patient doesn't wean off, we don't remove this and do some other strapping or a splint after 2 weeks, then the patient will have a stiffness in the PIP joint, which is again a great ordeal to talk. So ALUFOAM splint is a workhorse. Whatever we do, whether we do it manages conservatively or operatively, an ALUFOAM splint is very handy for using it. And what I want to stress here, sorry, yeah. So this is another example where it's a long ALUFOAM splint which can be used. This photo is quite misleading, but actually there is no the MCP joint is not in extension. It is actually in this way. And here the patient had a PIP joint dislocation. The proximal phalanx is fixed to the splint and he is doing the exercises. Gradually, we will increase this angle and make it neutral till the PIP joint can be completely made zero. So that's a conservative management of the PIP joint injuries, and injury around the PIP can be well managed by dorsal extension block splint. And this is another example of ALUFOAM splint which can be used. So yeah, this photograph looks very poor. Sorry for that, no good angulation. But here the patient had a fracture at the proximal phalanx of 2 fingers, and that's why we had put a ALUFOAM splint on the dorsal aspect. He came with this particular stick. This is a very nice thing for emergencies. But when he came to us, he came with the stick applied on the volar aspect with MCP joint completely in extension. And that is the problem, that if these patients don't take treatment or they don't remove this splint, then they can get into MCP joint stiffness very soon. So that should be avoided. Mallet finger, I prefer ALUFOAM splint on the volar aspect like this with slight hyperextension at the, I would say, extension at the uh, uh, the thinking is that if the patient is able to extend at least 50% of whatever mallet deformity he has got, a flex deformity he has got at the DIP, if he is able to extend at least 50%, conservative management will very well help. One. Secondly, I even use all mallet fingers conservatively where there is no subluxation, and they do actually very well. So the catch here is, of course, there are other ways. Some of my professors use a dorsal splint. They would remove this. This is a textbook picture, of course, but they would remove this foam and then use it. This also works very well. And there are some other types of splints in the market, which I think this one and the volar splint, ALUFOAM splint, are very, very comfortable. The key point is that the PIP joint has to be free. In fact, the active ROM of the PIP joint, which actually keeps the tone of the extensors and the lateral bands good, is very, very important as a part of the PIP mallet finger management. And I keep it for 6 weeks, 24 hours for 6 weeks, and then for 12 hours for another 2 weeks. Sorry, 2 to 4 weeks. And that depends on the tenderness the patient has got at that time. There is a skin maceration issue, and it may require a weekly or a bi-weekly removal and cleaning. So when that is happening, the other person, apart from the patient, would hold the finger in a particular corrected position and then clean this finger and again reapply this splint. I also tell the patient that if at all you remove this splint once, then we will count your splint time from that day. So all your whatever work you have done, that goes to 0, and we start the splintage day from that particular day. So and it works well. Fracture dislocation PIP joint, if it's a fresh fracture like this, and we have got less than 30% of the base of the middle phalanx, it gets reduced well, and then we can use this ALUFOAM splint to keep it in a flex position, maybe 30 to 40 degree of flexion at the PIP joint. And over the next every week, I would decrease this flexion by 10 degrees, so that ultimately at the end of about 1 month, the finger is completely straight, and it works very well. Once there is decrease in the pain, maybe about 7 to 10 days from the injury, patient can start gentle ROM at the PIP joint. At every point of time, as you see here, so this is fixed. The proximal phalanx, the splint is fixed at the proximal phalanx level. There is a Velcro at the middle phalanx. The DIP joint has to be free, and he has to work a lot. He has to keep moving this DIP joint. Otherwise, overall, we get some flexion deformity at the DIP joint if they don't do that. So that's another example of the same. A patient had an acute dislocation, reduced well. I immediately put the splint, put this splint and this well. He will remove this Velcro, put a finger here, and do the DIP joint movement. Otherwise, he'll remove this, put a finger here to block this, and do a PIP joint movement. So that's a case of operated case where I put an external fixator, reduced it, then put this dorsal blocking splint and made the patient do working. So that's one way which we were discussing. This is another way where many people do, and this is very nice because this particular type of arrangement avoids complete dislocation. At the same time, because this is not joint, patient is able to flex nicely. So this is another way of treating the fracture dislocation PIP joint and works very well. Kapner splint has to be used in cases where there's something like a volar plate avulsion injury or volar plate injury, and the patient has got slight flexion at the PIP joint. And if this is not used well, then the patient will develop some degree of PIP joint contracture very soon. So for that, Kapner splint has to be used. But when we use this, again, it should not be used for more than 15 minutes at one point of time. Patient may get discomfort and may remove it. So he should have a static splint always with him. And static splint has to be used, that is a volar straight ALUFOAM like splint has to be used at night also. So that whatever gain we have had throughout the day should not be lost at night by flexion of the finger. And this is a dynamic splint, we know about it. So this is again PIP joint injury where it's only a soft tissue injury. We want to give rest to the part. We can use a finger gutter splint here. This is operative case where I had to make a splint by using a syringe. Just for an example, I've put it here. But this is a lot of waste of time. I would prefer that we should have at least these three things always with us. Kapner splint. This goes out of stock very soon from the person whom we buy in Nagpur at least. This is a ALUFOAM splint, and the body strapping can be made very easily, and the staff makes it. So, sir, can I continue, sir?
Yeah, thank you so much, Samrat. That was a wonderful display of all these splint. So, questions from faculty member? Quite often, I would ask the first question. Quite often, this IP joint injuries with the volar plate injury, they develop slight flexion in spite of all splinting and all the measures you take. They ultimately land up with some amount of flexion deformity. Welcome, Tanna sir. Welcome to the meeting. The first lecture we had was on the hand splints. Sir, you are muted.
I was there. I heard quite a lot of it.
Yeah. So, Samrat, some patients who have just gentle flexion deformity after an injury, there is no bony injury. It's mostly a soft tissue injury. They land up with flexion contracture. And even if you give Kapner splint, they remain with some amount of flexion deformity in the finger. So what do you advise them?
Sir, I continue with the same splintage and exercise. That is, that's all we can do. I mean, nothing operative about it. But yes.
Jetwa sir, any? Yes, Tanna sir.
That flexion deformity, what you mentioned.
Yeah.
What is typically recommended is try to get that finger straighter out and put it underneath your buttocks and try to sit on that. This is what has been recommended officially. So It is the easiest way in which you can really stretch it out.
Okay, so stretching, physical stretching and splinting.
Push.
Yeah. Jetwa sir, you would
yes,
like
sir.
to...
Precisely what Tanna sir said, it is actually a passive stretching. And textbook says that the physiotherapy lasts up to 2.5 years. So nobody should be disappointed if there is no good correction of deformity. Wait, go on doing exercise. For the hand, it is the longest physiotherapy which is required.
Okay.
So maybe in course of time you'll get also.
And that minor flexion deformity really doesn't bother the functional of the patient. And so the patient carries on, and very rightly Jawar mentioned, you go on stretching it out. Slowly over the time it will stretch out without really functional problem as such in between.
Yeah. Another interesting question, problem in the OPD is the mallet finger. And whatever splint you give, some amount of terminal flexion remains there in this patient with splintage. So is it the defective splintage or yeah?
Sir, at the outset, I tell the patient that you will have some bump at the DIP joint, which should not bother you, and there will be 4 to 6 degree of flexion deformity in spite of the treatment. That's given in the book. So that is like before giving the splint, I tell them that. So there is no way we can. I mean, that is acceptable.
Any other faculty member?
And you explain to the patient that even if you operate, there is no guarantee that that minimal flexion deformity will not occur. And without operation also, you will have the same function which you will have it with operation. So I think they will accept that.
Yes, sir.
Otherwise, they say if in case it was possible to correct it with operation, why didn't you do it?
Right. Okay, sir, welcome.
In my part of the world, it is very often it is said, sir, if it can be done with operation, make me 100%.
Yes.
Yeah.
Harjot, we move along. We go to the next lecture.
Only one comments I would like to give for the POP slab. Instead of dipping into the water, try to use a spray. Once you use a spray, some 20-30% of the plaster particles which are going to go with the water will stay there. So even the thin layers will be so strong. You are not allowing any part of plaster of Paris to go out. So using a spray makes it a thinner yet stronger.
Okay, I'll ask.
Okay, sir.
The plaster of Paris one which we were using earlier, is it still being used?
Yes, very much.
Yeah?
Yes.
But I have never used it for last 20-30 years.
No. But
Probably,
that is not
I think it is the cheapest thing which is available, I believe.
That is not the one which we are making in the OPD, but is now the already prepared one, Gypsona type.
Yeah,
that we are using. Yes.
Oh, you are talking about the Gypsona?
Yes, Gypsona type.
Ah, sorry. Yeah.
Yes.
But Gypsona also the powder goes away?
Yes. Yeah. If you try to squeeze it fully so as not to have any air bubbles inside, you squeeze so much, then some part you can see in the water, it will be whitish.
Easily, you get old, you can't really squeeze it so hard and then it remains inside.
Atul Bhaskar, welcome to the webinar. Sir,
hello sir.
Okay, yeah, most welcome. Can we proceed with Dr. Tanna sir's lecture? Sir, can you?
Okay.
So that would be a very interesting lecture. So sir has put it as fracture clavicle management, conserve.
No, I have not put it. I have put it, my journey through the clavicle fracture.
Yes, yeah, journey through the clavicle fracture. Yeah.
First is this, Einstein said about the Charlie Chaplin. Einstein said, what I most admire about your art is your universality. You do not say a word, that is Charlie Chaplin doesn't say a word and yet the world understands you. The Charlie Chaplin replies, it is true, but your fame is even greater. The world admires you when nobody understands what you say. Now this is the cotton roll. These are the days I am talking about when probably 3/4 of you were not even born when we treated clavicle fracture. Whatever the splint which is available like this wasn't also available. So we made these cotton things, we made the string and tied it around the shoulder like the way we put this splint, and so that in the axilla, it will be a very tight axilla, we put it there so that the whole clavicle will be reduced. And the problem will be it will become loose. So we made it tight and strapped it. With the sticking plaster, we would strap it. So it does not become loose. And now the pressure in the axilla, so severe edema of the hand occurred. This was one of the common things to happen when we were too enthusiastic. So we cut it, and now face having loose slings applied for the mental satisfaction, and it changed it every week for whatever it was worth. By that time, it became gummy. 3 weeks, it opened it, and kuch naam ke vaste strapped it for 4 to 5 weeks. It held up, and all is well. This is how we treated our clavicle fracture, wherever it is, lateral one, middle one, displaced one, not displaced one. And we never found there was any problem as such. All of them did well. Whatever the few which had non-union, we treated them surgically. This is how it is done. You put this strapping, try to reduce the clavicle, what's supposed to be, and we did this. Same thing we did it with the splint. This also is tight. And Eddie Masto loosened it and retightened it every week. Some paid for the retightening, some did not, but still the life carried on. And the new fashion were introduced. This type of a splint came into picture. This was the clavicle splint, like a Visco and other companies, they provided it for good or bad. And the children's splint didn't come earlier. This was only meant for adults, small, medium, large. So children also still we had to put in the same cotton roll we used to put in children, and that is what we carried on. But then even the children one also arrived. So till now the evidence came that this figure of 8 is not needed. So now some people applied this strapping, some people applied only this arm pouch, some people applied this arm pouch with the shoulder immobilizer, and this life carried on. Only time we operated was a non-union with a recon molded plate. This was a 2 years non-union. This is a recon plate, and there were no locking screws around. And this is with the ordinary screws. We carried on, and this is in 7 months' time, the whole thing heals up. This was the typical non-union we treated. And this is the way everything went on. This is again a 3-year non-union we treated with the ordinary plate. Then the commerce took over. And we added one more fracture for a surgical treatment. It was done methodically by the creating an evidence first. Then Evo came out with the clavicle plate, and hamara log ka takdir khul gaya. Because one now clavicle commonest fracture, he started being operated. So why fixation of the fresh fracture? Long-term results of a grossly displaced fracture not satisfactory. They all improved, gross deformity remained. This is what the literature is talking about. I am not talking about it. Though the deformity itself is not very important, but functionally higher non-union rate. And even if ununited with malposition, function is compromised in strength activity. And the results which were declared by Harvey cited the results of meta-analysis of 2000 plus non-union to be greater than 15%. In comparison, complications of fixation are usually nothing more than a local plate irritation and possibly numb area that gradually shrinks to the size of a quarter according to Harvey. This is what now I say it is stupid. I think it is not the way in which it really behaves. Another evidence, conservative not always good results. Recent study higher non-union rate and a poor shoulder function, which was very appealing because the non-union rate we all saw, but they also said the poor shoulder function, a spectrum of injuries with a diverse functional outcome, each requiring careful assessment and individualized treatment. So as a goal, फिरा के सब बड़े बोलने लगे. Non-operative treatment compared to the plate fixation of displaced mid-shaft clavicle fracture, surgical technique, surgery better functional outcome compared to conservative. This study supports primary plate fixation of a completely displaced mid-shaft fractures in an active adult patient. Therapeutic level evidence 1, that is what they claim. Now here was the clavicle fracture, and if you did nothing, then this clavicle fracture heals up. This is fully displaced, as you can see. This is a callus formation. But then it has been claimed that shoulder-sternum distance reduced. And that shoulder-sternum distance functional affected even though the fracture is united. Like this is supposed to be the united fracture. This distance is smaller than the normal distance. And healed clavicle fracture treated non-surgically, note the bump and the shortened shoulder with the subtle droop. This is how it was considered. This functionally, this is inferior. And then another literature came out, this muscle is pulling, this muscle is pulling. We all know it very well. And N started the primary plating. In a 30-year-old, I did this primary plating, displaced fracture, did this tibia. Since it provided a good plate, so leg screws and locking plate and everything started. And we prospered because we now operated one more indication for surgery, that was a clavicle fracture. Indication of surgical clavicle fracture, relative indications for surgical treatment have been expanded. High energy closed fracture with a greater than 15 to 20 millimeter of shortening, fractures with 100% displacement and comminuted fractures. And a typical me who has to do all new surgeries first, otherwise most modern surgeons doing all complex new surgeries stamp on me will be hurt. So I had to do all of them. And one of the few who spoke in the all meetings, and I was highly qualified, one of the few who had done enough to speak. So once you are speaking, you have got to do it more. So this is what I carried on. Leg screw, fingers, plate there, another one, which went on doing it. And this got infected. Now this got infected, the problem starts. Now the infection, plate removal, ding, on all those things which we see. So this was one of the first problems which I faced into this. And these are the elevation of Alizar House. They all started this. This is not my idea. This is why some people started doing this for a clavicle also. And then there was an evidence which was created that the inferior plate is better than the superior plate. It's damn difficult to do an inferior plate. I have tried to do it. It's not very easy to put it. Either an anterior plate or a superior plate is the easiest way to do it. We have reported better cosmetic and less irritation. So recon plate is inferior to the thicker plates, say WIS, because the recon plate can bend down and can have problems. And it can break down. So this is the operative problem. So now you got to use a thicker plate and not a thin recon plate which we were using. And so this is how the thicker plate started. This is now recommended. This is what is the fracture, you got to operate this. And the skin incision, then I spoke about it. Pull this down, take the skin incision so that the skin pulled up and the bone exposed, so avoid the skin over the plate. And it will be cosmetically good. And there are 6 nerves like this. Every time I had done the plating of the clavicle, I would try to dissect out the ones. And I could find it out 4 of them. Other 2 probably on the way, it would go away. This plate on the tension side and anterior posterior position, anterior inferior is better for cosmetic, but inferior in biochemics. And these were the newer plates which arrived by synthesis. All beautiful plates came in. Reconstruction plates are more easily contoured and have been used with success. However, they account for a number of failures and should not be the surgeon's first choice. This is how it was talked about. So these plates came in, locking plate came in, and this is how we started doing with the contoured, pre-contoured plate, strong plate. So now the only question is if you're doing a superior plating, this is how I spoke in the meetings, drill one cortex, then readjust the sleeve length to avoid the soft tissue injury lower down. So you put in the sleeve, drill sleeve on the jack-up chuck, so that now only you will be able to go this much. This is what is still recommended if you do the plate so that your drill inadvertently won't go all the way up. Biomechanical evaluation of clavicle fracture plating technique. Does a locking plate provide improved stability? Superior position, thicker locking plate, superior to a non-locking plate, then superior to the recon plate. And that's why this locking plate, thick locking plate came in. And my conclusion in those meetings was, post-operatively unrestricted motion is allowed, with the exception of no overhead lifting for 6 weeks, provided stable fixation was achieved. Often the pain relief associated with stabilizing the fracture is dramatic, and the efforts to limit the patient's activity need to be emphasized. In conclusion, locking reconstruction plate is easier for fixation and thicker plate is better. This is I concluded. And then in a young girls, you don't want a scar here. So then this percutaneous small wire came in. This is Dr. Thakur's case. Flexible nail came in. And now even this comminuted fracture, which you do not operate, this became an indication for surgery. So this also we operated. And the intramedullary nailing was done for all this sort of a fracture. And this is the real indication, if at all, is the hanging shoulder, where the clavicle fracture, shoulder fracture, neck fracture, where you go to fix it up. Dr. Gadigune's, this is Dr. Gadigune's nail. This is the one which I did it. And this is the one which is been talked about, where this is where it locks in onto the outer side, so it doesn't move up and down. This is Dr. Gadigune's nail. This I feel is today probably one of the major indication of fixation of a clavicle. The complication of nailing, brachial plexus palsy after intramedullary fixation of a clavicular fracture. There is articles which appear. And so with the literature up to date, I put thick locking plate and see what happened. Thick locking plate. Now you can count every hole and there is the scars which form in. So I have replaced a bump with this scar. This scar, keloid. All these things started. So then now I had a rethink whether what am I doing is right. And I concluded that probably I am overdoing it. So, and here it is. This is the non-union, and this has been moving around, and lots of people have seen it. Nobody was to touch it. And these are the nerves here. I started off 4 nerves earlier, and then when I finished the plating, there were only 1 or 2 remaining. All others had gone. So that paresthesia remains all the time here. Again, these are the problems. Look, if you had not done anything, probably the fracture would have held up. This is what happened. So, sau chuha maar ke abhi billi haj pe chali. I almost gave up surgery for the fresh fracture clavicle. This is what I talked today. Only non-union I operate. This is the one which is one of our nurse husband, fully displaced, was advised surgery. I said, you don't need surgery. I put him a splint here, and this is 2 months' time. He is perfectly all right. Everything is healed up. We were ever so grateful. So, now I am not talking about the lateral end. It needs still surgery almost all the time, and separate plates are available. I am not talking about this. This is still needs surgery. So, in conclusion, I have traveled through the whole journey of a clavicle fracture. Today, I talk on surgeries I have given up. I talk about the topic where, what are the things which I have given up? And one of them is a clavicle fixation of a closed fracture is one of them which I have given up. So today for me, the indication for surgery of the clavicle is open fracture. Still it is indicated most of the time. Mid shaft displaced fracture, most of them I don't operate. Neurovascular compromise, yes, you operate. Floating shoulder is one of the major one. And painful malunion or non-union. Painful non-union. Malunion hardly ever needs anything. Non-union, so many of them are not painful. So it may not need anything to be done. If it is painful, then only you need surgery. And thanks, brother. Did you know that in Germany, there is no punishment for a prisoner who tries to escape from a jail? Because it is a basic human instinct to be free. It is exactly the surgeon's basic instinct is to operate. And that is the reason we are pardoned if we operate something which is not indicated. Thank you, friends.
All right. Thank you. Thank you very much, Dr. Tanna, sir. The resurgence of the... Sir, am I audible, sir?
Yes, yes.
Sir, the resurgence of the intramedullary nailing, the similar one propagated by Dr. Gadigone, there are other varieties of the nails also. So your thoughts about that nails, sir, because you have mentioned clearly. The second question is, the indication for clavicle fracture is the tilting of the skin, the thick skin that's just about to come out of the skin. So your
As I
thoughts
said,
on that thing, because
as I
it's pretty
said,
difficult to manage.
now the indication is when that piece of bone is just underneath the skin, where it can come out and it can produce a fracture, which is going to be a compound fracture. Very rarely it is seen. The wiring also, which Gadigune does it, I still would do it only for a hanging shoulder. For an ordinary clavicle, I have almost given up surgery. I feel it is not required, because even in that wiring, Gadigune's wiring, in between you'll have to open it up most of the time in order to be safe. You'll have to make a small mini incision. And the oblique fracture, if it is there, then mini becomes a maxi incision. And then it becomes still cosmetically an issue there. And still it is not as solid a fixation as a plating. And hence that wiring probably indicated as a wire media, but whether it is going to replace the plating, I am not sure.
Okay.
Yes, Dr. Chandok, you want to say something? No, you are muted. You are muted, Rajendra.
Sorry. Amongst the various splints and braces, etc., what is your current flavor you are using? Is it just a sling or a belt or whatever? So amongst your brace current flavor?
You are asking whom?
To you, sir.
For clavicle.
No, I think now it is only at the arm pouch. You put in the figure of 8, but comparatively non-functional figure of 8, because if you try to put it really tight, then it is uncomfortable.
Okay. So for a patient who comes with a brace and an edema, you remove the brace.
Yeah,
and for a person who comes with a sling, then we add up a brace and a strap.
Yeah, so it is all, we just do a small data here and there.
Okay. Thank you, sir. Yes, sir. Sir. Yeah.
Yes, I just wanted to say that we need to learn a lot from clavicle fracture, because it has put our old principles of fixation in orthopedics absolutely down to drain. All these things which happens in clavicle, which is maximally uniting without any effort, is showing us that all our principles are something absolutely contradictory to what we are doing. For example, 100% shearing force, it heals. Membranous bone, it heals. Subcutaneous bone, it heals. No mobilization, fully mobile, it heals. So all your principles are absolutely questioned. Why to talk so much about the fixation and interfragmentary screw and this length and anatomical plate? What? Nothing works, it simply heals. So the whole orthopedics need to understand that what exactly is there inside this primary hematoma of clavicle, which helps healing in spite of everything on the opposite side. And that is, I think, it's very, very important to understand.
And the evidence which was generated, the shortening of the shoulder curve from length to the sternum to this, I doubt very much whether any one of us have found really a functional handicap to the patient, which really overlaps a little and it unites. I don't know whether any of you have found that problem.
No, sir. It is in the book where we go for a permanent disability and give some statement in courts of law. That book has from 2% to 6% of disability when there is a malunited clavicle fracture. And malunited is easy to say, but you are very true. Actually, in practice, nobody is having this problem.
Yes.
And I was so many times surprised that suppose I am only a 25-year-old surgeon, and in the meeting I say that I can treat clavicle only with the sling. Then people will say, oh, Dr. Jethwa, please go down. We are talking about fixation. We are talking about internal fixation, best reduction. And you are talking only a sling will work? But it works. It works. So there is the point where all this deformity and this all problems, it doesn't work functionally. Functionally, people are very much happy.
Yes.
This is what exactly happens to me, Jawar.
Yes.
When I start off these things, all those surgeries which I had done, and people ask me, Saab, you started the surgery for us. So we all started doing surgery. Now you are telling us, don't operate. This is how the things are.
Yeah, Asim sir, you wanted to say?
Sir, yeah. I had a clavicle fracture about 16 years back. And the elbow pouch really helps to support the weight of the arm. And one practical tip, they find it extremely difficult to sleep during first 2 or 3 weeks. So all the time you can't lie down supine. And on that fractured side, it's impossible in spite of very strong painkiller. So at least you should be able to turn on the opposite side and you keep your arm like this and put 3 or 4 pillows. So it's not given in the book, it's innovated.
Yes.
So elbow pouch works. The pillows, 3 or 4 pillows to support the arm so you can turn at least on the opposite side and sleep peacefully. And I could operate 3 hours case, third day of the clavicle fracture.
You yourself had it?
Yeah, I had it. And it's absolutely normal. The next X-ray was taken after 3 years for some insurance purposes. Third day onwards, sir.
ये साला बनिया नहीं है, भाई ये बनिया को भी शर्माता है ये.
Mukhi sir wanted to comment since long. Mukhi sir, you unmute yourself. Mukhi sir, unmute yourself. Mukhi sir, you are muted.
Yeah.
Mukhi, you are muted.
Yeah. Thank you, sir, for your vast experience. I have seen a young lady who presented to me after plating, and she would not only allow her husband to touch her breast, even a boyfriend of hers, she would not allow to touch the breast. There was so much paresthesia, and she could not sleep. So plating in my career has been the worst in clavicle fractures, and I always take a vertical incision. I just open that much of the fracture site, introduce the plate on this side and introduce on this side. I never take a longitudinal incision. What is your opinion on this, sir?
On longitudinal incision, sir, comment?
Yeah, all vertical in the lines of Langer's lines.
Yeah.
And I never take it along the clavicle.
अभी तो हम बोलता है you don't need surgery. अभी हम तो ऐसा बोलता है ना.
Yeah, right. When you need it, then you do it vertical. That is for your non-unions. That is when
horizontal.
Yeah. Atul, any comments for any clavicle fractures for children?
So I think what Dr. Tanna said is really, was apt for children as well, because there was this move of treating adolescent children with plating as well, because they felt that many of them are sports person and they will lose some shoulder biomechanics. So there was a big move of plating. But currently, what is the flavor is if it's displaced and it's an athlete and he wants to maintain shoulder contours, and then flexible nails is a good option. Flexible nail, because in children they will heal. Adolescent children, you just have to align them. So plating usually is not required, but there are papers looking at the flexible elastic nails where you just align the bone and it will heal. So, but that is for a fresh case. I'm not saying for non-union and routinely, we break the clavicle sometimes when you're doing these spangle deformity. We actually sometimes do a controlled clavicle osteotomy. And we let it heal in whatever position it has to heal. So I take the point that there's no real indication in children to operate unless the indication what Dr. Tanna has already mentioned. So the move has come back to conservative treatment as well in children.
And you use a figure 8 brace for them, or just a sling, or
just a sling? I think the aim is to prevent the weight of the whole arm going on the fracture side. So this figure of 8 bandages, I remember when I went to UK, I tried to put it in the first time. My boss told me, "What the hell are you doing? You tighten the bandage, it causes more pain in the child." He said, "Just put a collar and cuff. Collar and cuff in a child is good enough."
Okay, perfect. Mukhi sir, you wanted to say something? Then we go to the next lecture.
No, I would say that anybody has read the book De Palma, Conservative Treatment of Fracture Clavicle. Just go through that book.
Any specific inputs from that literature?
Yeah. And he says how to get almost 99% union, except those 4 cases where you are bound to operate, that is the hanging shoulder, or that is the superior suspensory ligament, complex shoulder problems, or when there is a vascular damage or a neurological damage, you have to operate on that. other conservative treatment of deep armor's bandage that puts the shoulder up from the olecranon down to this clavicle. And what a marvelous reduction he has got. Just go through that book and it is freely available, free of charge in Book Hub.
Okay.
Marvelous. Nobody reads it.
So,
तू हमको बताना कैसा करता है वो. You have read it, no?
Yeah, you give the 3-sling bandage, which is comfortable, not tight. Just put a bandage across the olecranon onto the shoulder, so that otherwise what happens? These people, they keep on removing this. The bandage which you put, he goes to the bathroom, he removes and takes a bath. Here you don't have to just. It's a question of just 3 weeks. It becomes gummy.
So something
And
like
then
a
the battle is won.
yeah, something like a acromioclavicular subluxation.
Yes, yes.
Okay.
You just put it like this, and even the bump is minimum, and the patients are extremely happy. I have changed over to deep armor's technique.
Okay.
Honestly.
Why Dr. Mukhi, it has not become a universal treatment? Because I think he has written it in his book, which is, as I said, it is very easy to write a book. But when you want to really publish a literature where people can question you, then it has not become a universal treatment.
No, this book is a French book. And what literature we read is from UK and USA. And
Not
same
anymore.
is with the reverse,
No,
reverse shoulder.
it is not anymore. All of them are being translated and they are seen. The Chinese literature, which has been so very well quoted.
Yeah, I agree.
Anyway,
But now,
Yogesh,
Yes,
we
sir.
move on.
Yes.
Yeah, thank you so much. We had a wonderful discussion on clavicle fracture.
Yeah, we now move on to Dr. Atul Bhaskar. And as a pediatric orthopedic surgeon, knowing his views and ideas about supracondylar humerus fractures will be very interesting. The techniques and the way he manages it is the thing what we look forward. Yeah, over to you, Dr. Atul Bhaskar.
Yeah, I'll just share my screen.
Yeah.
Yeah.
Sorry, 1 second. Just go to the share screen. 1 second.
Yeah, no problem. Take it easy. By that time, we'll have 1 or 2 questions. Any questions from the faculty members for clavicle?
Yeah, this is about the issue raised by Dr. Jetwa sir and strongly supported by Dr. Tanna sir. The issue of operating of the clavicle has been greatly promoted by the literature. What he has rightly said. It basically it amounts to a very select segment of elite sports people for whom the shoulder strength becomes a little compromised with the shortened clavicle, the scapulothoracic dyskinesia, what they really mention about it. Sir, your thoughts on this thing?
Well, I don't know. We have to find out in literature there how many athletes are having a non-operative treatment.
Yeah.
And what exactly are they facing? But it is not that common. They
It's
usually
not that common. Yeah, it's
not that common. But very important thing is that if you want to predict how much malunion will occur, then there is a very good suggestion in the literature that you take X-ray in supine and take X-ray in standing position.
Okay.
And then you see what is the displacement which occurs. And then you can explain to the patient and say some about the prediction of how much malunion can happen.
Yeah.
So that way you try to see that what would be the ultimate result.
Because basically what happens is in the OPD, we have an X-ray of only one particular clavicle. Actually, we should have an X-ray of both, showing both the clavicles, so that you come to know exactly how much shortening the patient might have in the days ahead.
Yes, that is true.
All right.
Yeah.
I think Atul
ready?
ready?
Can you see it?
Please.
Yeah, we can see now.
Please go ahead.
Okay, so my talk is going to be on the conservative treatment of supracondylar fractures. So it is the third most common fracture which is seen in practice, but again, it generates maximum discussion, and that is because of the lacunae in the current classification what we use, which is the Gartland's classification. Now, this classification doesn't consider what is the soft tissue extent of injury. It doesn't tell you about any criteria for reducibility, and also doesn't predict whether there's an neurovascular injury. So this kind of classification is very simple, 1, 2, and 3, but there are lots more to it than a simple grading of the fracture, and you have to look at the soft tissues as well. And what has really been missing in treatment and in textbooks is the sagittal malalignment in these fractures, and what is acceptable and why. Because many times we try and we are very obsessed with the varus malalignment, but it is the hyperextension which is the first component of the deformity, which can then progress and lead to rotation. So just a couple of cases. This is a 5-year-old child with this fracture, and you can see that he's been treated in a back slab, and you can see that this is not an acceptable position at all. Another child, this was a 6-year-old child, type 2 supranuclear fracture, again treated in a back slab, and you can see what's happening here. This is the anterior humeral line, and this is the line along the fracture plane, and I'll discuss this. So whether it is poor casting technique or whether it is inherent instability which causes the loss of position is debatable. But the key thing is that if you have a poor casting technique, chances that you will get blamed even if the fracture is inherently unstable. And again, I would always recommend that you measure the deformity. Goniometer is the simplest tool you can use, and you measure and don't eyeball the deformity, because that's one way to predict what will be the level of remodeling as the child remodels. Now, current flavor of treatment for any of these fractures, type 2 and type 3, is a closed reduction and SOS spinning. But the key thing about the technique is that you give sustained traction. All of us have studied this in medical in our residency, and then try and hyperflex the arm so that you reduce the distal fragment. But the important thing is don't keep the cast in hyperflexion. If you keep a cast like this, you'll end up with a lot of problems, and compartment syndrome and getting skin problems in this cubital fossa is very common. And you'll always find that child will have a lot of paresthesia if you flex beyond 120 or 110 degrees. So ideally, a typical cast would be in this position where you have got a nice 90-degree molded cast and you are supported well so that the child is uncomfortable. Extension casting is done only in certain cases, but it requires the internal fixation. So extension casting is done for flexion type fractures, but you would always pin them and put them just for pain relief in an extension position. But this is not recommended for a close treatment. So this was a child who had this fracture, this X-ray presentation. This was the AP view where there's lateral impaction. So this is in valgus. And then just 2 days later, when he came back to the clinic, you can see his soft tissue swelling is increased and the fracture is displaced. So no cast was applied. He was just simply put in a sling because this was felt to be a stable fracture. And then this was then manipulated and put in a cast. So most of the children will need a well molded cast. Avoid too much padding. Do not flex beyond 90 degrees to achieve a stability. If you have to flex beyond 90 degrees to 100 degrees, you must pin them. Otherwise, you will get a problem with compartment syndrome. And again, try and get a cast like this at 90 degrees, either in supination or pronation, whatever is the best position of reduction you get. If there's a lot of instability, sometimes we can cast in semi-extension at about 45 degrees, and then this cast can be changed after a week. But the reason I mentioned about the sagittal alignment is this thing. This child who came back at 6 months follow-up, the first one I showed you, this was the healing at, and this is 18 months. So he had this gross hyperextension deformity with the parents. Usually, this will remodel over time, maybe 3 or 4 years. But because the growth of the elbow is much slower than the humerus, parents are always concerned about this cosmetic bump, although it doesn't affect any function. Similarly, another girl, you can see this 28 degrees malunion, which was then reflected in the hyperextension and restriction of flexion. This is an 8-month follow-up. So I would, pay close attention if you're treating them conservatively to this sagittal view as well, because these things can be very unsightly, and parents will always seek different opinions whether anything should be done. But we always have the varus obsession with any of these supracondylar fractures, and this is not unknown because many of the displaced fractures, if you treat them conservatively, will end up with this kind of deformity, what we call the gunstock deformity. So the key thing in any of these fractures is not to miss the sagittal profile. So we look at the anterior humeral line, and you should ensure that it at least cuts the 1/3 of the capitulum. So this child earlier, you can see, who was put in a slab, the humeral capitulum is behind this line, and this will lead to hyperextension deformity, even rotation, and can lead to cubitus varus. So very, very important to pay attention in any of these post-op X-rays to look at the anterior humeral line. So this was the same child I mentioned earlier. He had this hyperextension deformity, and there he had about 20-30 degrees of hyperextension. So important to document this, and you can then counsel them for accordingly for the remodeling. The other girl, which I talked about earlier, again, whether it is purely cosmetic or functional, very rarely the functional problems unless they are doing overhead activities, but more or less it is mainly cosmetic. So again, only treatment for conservative treatment of supranuclear fracture is the type 1 only. So type 1 is totally undisplaced, and you can see that the anterior humeral line will cross the capitulum. So you have a fracture like this, you can treat them conservatively. Otherwise, if you have a type 2 fracture, you must take exercise every week for 3 weeks. I don't know whether it is practical, but at least you should write on paper if the patient follows up is good. But emphasize that in a type 2 fracture to come back within a week if there's a lot of swelling. But this is a type 3 fracture which are treated. You can see the gross soft tissue swelling and it was reduced, and this was the position. It's not a bad position, but obviously there's a limitation of how much you can treat in a cast, and this fracture obviously displaced and ended with a varus deformity. You have to be careful of what is a type 1B fracture, which is undisplaced fracture, but there is medial impaction. The medial impaction is the one which will lead to varus deformity. So these ones you should be very careful. Even in the sagittal, you can see the loss of the anterior humeral line and these impactions. So these fractures must need a close reduction and percutaneous spinning, although they may be minimally angulated. So don't ignore the type 1B where there is varus impaction. But there are some papers looking at the failure in type 2 fractures, and it says that almost 48% of them can lose reduction without pinning. So type 2 are the ones which is a gray area. It's sometimes not easy to diagnose an X-ray, so you need a follow-up X-ray as well, and they give the maximum problems. Similarly, the key thing which I mentioned earlier is the degree of extension of the distal fragment. So what is acceptable today is about 5 to 10 degrees, not more than 10 degrees. If you have more than 10 degrees of extension of the distal fragment, it's best to do a close reduction and pinning to prevent a failure of the non-operative treatment. For example, this is a child who was treated conservatively. You can see the displacement on the AP view. This is displaced on the AP view as well, and even in the lateral view. And this hyperextension leads to rotation. So extension, angulation causes rotation and a cubital varus. So there is a very high risk of displacement of these type 2 fractures which are treated conservatively. So this was a very good paper. We looked at the fracture with need fixation. So the varus impaction always needs fixation. When you suspect rotation, you always correct them and fix them. These ones you can get away. These ones you can treat them conservatively, provided you don't have more than 10 degrees of hyperextension. So this is a very good table which they looked at. And so these type 2F fractures, where there is a loss of reduction more than 15 degrees of less than 15 degrees of the supranuclear axis deviation, you must put them with close reduction and pinning. And if there's a lot of swelling, again, they would recommend pinning even for the type 2 fractures, because these tend to then displace in the cast. So we all know the technique of reduction. This has been well described. Again, just to re-emphasize, you need an assistant, or you should push back on the proximal fragment and insert the wire in the lateral position if you can, and then pass this wire into the proximal fragment. You can put a roll up on the underneath the proximal fragment to elevate that, and then do close pinning, either 3 lateral wires or a cross wire. This was a technique published by Dr. Patwardhan from Pune, where they strap the arm to the arm board. So they use the board technique. So there is no rotation of this fragment, and you just rotate the C-arm, and you can do a close reduction and pinning with this technique. So you reduce and fix, but don't malfix. So it's very important to follow the principles. You try and get wires, the cross wires above the fracture site and not at the fracture site. Make sure wires have adequate length and adequate strength. Otherwise, you will get a poor fixation. So something like this, where you cross at the fracture site, where you miss the fracture completely, or you bundle with too many wires, and that causes malunion of the distal fragment. So there are some indications for good reduction. You look at the Bowman's angle, which you can measure, which is the capital humeral shaft axis, which is about 75 degrees. Very rarely done in practice. What we usually follow is the anterior humeral line, where it crosses the capitulum. I think that is much easier and practical to measure. And of course, we have the other line is the humeral shaft axis and the capitulum axis. So this should be around 50 degrees. this line and this line along the capitulum. Again, I've seen that even when people do open reductions from the posterior approach, which I very rarely do from the posterior approach, there's a tendency to hyperextend the fragment. So you see this child underwent a fixation, and they have reversed the capital axis. It is still in hyperextension, and this child then ended up with a hyperextension deformity. You can see this is where the capitulum is. So while doing an open reduction from the posterior approach, with many of my adult colleagues do it, you tend to hyperextend the fragment. So that is why I prefer the collateral approach or the medial approach, or sometimes the anterior approach. So just in conclusion, you must be aware of the varus tilt in type 1 fractures, be aware of the flexion type fractures where there is rotation but not much angulation. In less than 12 years of age, up to 20 degrees is acceptable. And the flexion type always need fixation because they are unstable. Some studies from literature, the type 2 fractures are associated with both satisfactory and unsatisfactory results, regardless of the type of treatment. So these are the ones which are the gray area. Spend more time treating this, seeing the X-rays, counseling the parents. Type 1, 75% will get good results with closed treatment, and type 3, almost 76% have good results according to the Flint's criteria. And you can see that even with open reduction, you can get some loss of elbow motion. You can get some loss of carrying angle because of overgrowth. But by and large, functional results are excellent in most of the children with type 2 and type 3 fractures. So thank you very much for your attention.
Yeah, thank you very much. Sir, do we have any questions?
I have a comment that in a chubby child or in a children, when you do conservative management of supracondylar, we depend a lot on ulnohumeral view. That is one. Second is we have to have cross-stable IITV lateral view, not by just turning the hand. And third, which is very important, is that fixation by plaster is because of the flexion at elbow. You just cannot hold humerus. It is the flexion of the elbow which fixes by the taxis of the soft tissues. So flexion of the elbow should be there, maybe up to 120 or 130, but you have to be very careful for the distal pulsation. So in those cases, when you feel like that you cannot apply a cast, you have to go for a splint. But it is the flexion which fixes with this, and that makes a difference. But otherwise, once you get a good reduction, particularly you have to see this medial combination from the ulnohumeral view. And that is the view which will give you a more good idea, because we need to keep it in. But in extension variety, yes, we have to, quite a time, we have to operate.
Atul, you said you rarely use nowadays a posterior approach for open reduction. So if you want to open reduce these fractures, what approach do you take now?
So sir, if there is a type 3 fracture and there's a proximal, the fragment, the spike has come out of the skin or nearly tending the skin, then the injury has done a dissection. So I'm very, very comfortable with the anterior approach. So I just take a small transverse or a lazy S incision. The fracture has done the dissection for you, and you're right on the periosteum. You put a K wire, stabilize the proximal fragment. You can hold it in proper rotation as you want. Then align the distal fragment and do as you do a closed pinning. Only word of caution is I always now, when I'm doing a medial wire, either if there is a lot of swelling, I would take a small incision. Because I had one child who I went through the nerve or very close to the nerve, and I removed the wire on the second day. But it took 6 months for the child to get his paresthesia under control. His power came back, but he was very, very sensitive on that finger to touch. And I think I would, in a very, very swollen elbow, it is better to make a small mini incision, see the nerve, or at least palpate the nerve and put the middle wire. So if I'm familiar with the anterior approach, otherwise I would do a middle approach because I can see the nerve, and lateral wiring is much easier. So, if I have to open a fracture, I would do from the medial side or a collateral, but very, very rarely, almost never do a posterior approach, never.
So in a pink pulseless hand, do you always do open reduction or percutaneous pinning and watching for next 24 hours?
Yeah, so that's a topic I didn't want to cover because it generates a lot of discussion. So if you have a pink pulseless hand and you can reduce the fracture, if you can reduce the fracture without any anterior soft tissue interposition, you get a good capital humeral axis, you pin it. By and large, if the finger stays pink, nice and pink, you can leave it alone. You need to keep the child under observation for 48 hours. Now, there are times where I have taken the child in for manipulation and I've lost the pulse during manipulation. And that is the time where I would actually, you don't use the oximeter, it is not very reliable. So when you lose a pulse during the manipulation, or you feel that when you flex, like Dr. Jetwa said, when you flex beyond 120 and the hand starts getting pale, that means there is anterior soft tissue entrapment. Either the muscles which is tending the vessel itself, in those cases, I will not hesitate to open. So if there is on-table pallor or there is loss of pulse, I will not hesitate to open it.
Another good thing which we have started is we have just drawn all angles like a wheel on a transparent sheet. We just superimpose over the IITV screen.
Correct.
Because so many times it's difficult to judge whether this is properly reduced or not. So all these angles, other things, you just can superimpose with that transparent sheet, and you can be more sure about whatever is the reduction.
So you keep these transparent sheets in the theater itself?
Theater, yes. So I asked the resident to just superimpose and try to see. By that, you are going to spend some time to change the position of the limb, try to see that. Otherwise, it may be an oblique view and everybody says it seems like to be a very good reduction, and then you go away. And in the evening, when you take X-ray, and you find that the spike is rotated.
Okay. Tanna sir wanted to say something.
As some of you might have heard me long back, I had treated them intracondylar fracture. In our days, it was only conservative. And I think I started saying that you get a cubitus varus in 62% of the people. I'm talking about they were pure conservative. I started the Thomas's fraction. I think if some of you might have heard it, it was published also, that it was proved that the varus is because of the fracture angulation. It is a proximal fragment and distal fragment, and angulation it gives the varus. Proximal, any displacement, side displacement, front displacement doesn't give you varus. So all what you need to do is under traction, you will keep it apart wherever the fracture is, and you will get 100% no cubitus varus, and the range of movement, which may be restricted initially because of the malposition, will recover. There was a lovely article who mentioned about that he would immobilize the fracture into full extension so that to see that there is no varus or valgus. Primarily, I'm talking in those days where we were not doing this KY. And he would do in a full flexion. You can adjust the things exactly according to the other one. That's all what is needed. And he says that whatever is the position of the bone, it is going to remodel. So once you are putting straight, then it's not going to give you any varus or valgus. And whatever the displacement is going to remodel into this child. And if at all there is a flex, there is a anterior posterior, which is SLAB, or anterior posterior movement, which is there. Initially, there may be a restriction of flexion, but which comes back in about 6 to 8 months or a 1 year time, as soon as that hump goes more proximal.
That's
Atul, any thoughts on that?
No, sir, I've actually had the honor of seeing that treatment when I was with Dr. Dheer. Dr. Dheer very rarely allowed fracture clavicle fixation, and we used to have these children in the ward with the Thomas's splint. They would be there for 1 week or 10 days, and we would call them back. So I've seen this treatment, and we've gone around the clock where it is not one easy to do this technique. It is not being taught. It needs a lot of close supervision, like you do a Thomas's splint. So I think it is more out of now, as things are moving in trauma, is to get the child back to his environment, and because these children have to be in the institution. So I remember they used to be in KM ward with Dr. Dheer when I worked with his unit. But the other units started doing open reduction, and I was seeing a lot of posterior approaches in KM those days. Very rarely anybody would take a collateral approach. And the other thing which Dr. Jetwa mentioned about putting the transparency, I think the good point is not about transparency, it is about measurement, about documentation. I think that's the key thing. Whether you use a transparency, use a goniometer, it is worth having some documentation in the OT, in the follow-up X-ray, so that at least you are more alert to any displacement or discrepancy which may happen in the cast. So I would always encourage my residents, just use a goniometer. It's a simple tool to use, and you can get valuable information, and you can counsel the parents. So, both are very, very good points about Dr. Tanna also. Very rarely children would come with stiffness because they would all come back in 6 months, moving the hand. but I think treatment has evolved just like in most things in pediatrics. Thank you, sir.
Thank you very much. Moving ahead, now we come from elbow to the wrist, and we have three very good talks on distal and radius. Arjut, can we proceed with the talks?
Yes, sir. I would like to invite Dr. Vijayanand Lokhande, sir, to present his talk on distal DS fracture. This will be followed by Dr. Gadge and then Dr. Mukhi. Welcome, sir.
Good evening, everyone. I would like to thank all the moderators, Dr. Jandak sir, Salpade sir, and Arjot sir, for giving me this opportunity. So actually, this treatment is new for me. I haven't been doing this for long, because in our residency days, the patient's pain never had that much of value. So we always used to just pull and apply a splint. But I would sincerely like to thank Dr. Mohapatra sir, without whose guidance I would have never tried this hematoma block. So it would be an overview of the indications and the contraindications, prerequisites for this block, where, when, and how to do it. It's a small talk. So there are some specific indications for a hematoma block, reduction of a distal radius fracture under hematoma block. So there are two varieties. They can be done as a temporary reduction maneuver for extraarticular and intraarticular fractures, for splinting them appropriately, to take some traction X-rays before going for an operative procedure, and they can obviously be dealt with definitive fixation of these fractures. There are some contraindications. The patients who are allergic to lignocaine, an open fracture, contaminated skin around the area of injection, and a relative indication is an old fracture. So prerequisites are, it should be done in an acute or a subacute fracture setting. Usually it is said it works well within a period of 8 to 10 days. There should be a written informed consent about the procedure, and the patient should also be informed that this block will not work sometimes. It's not that it works always. Sometimes it won't work. The patient should be non-allergic to local anesthetic. A sensitivity testing should be done prior to this block. Intravenous access is very important. Even in case if a patient gets some complication due to this block, or he develops some sensitivity, we should have an intravenous access so that we can manage that complication well. This procedure should actually be done in an emergency room which is equipped with routine monitoring system and life-saving drugs whenever applicable, and ideally it should be done in an operation theatre. So coming to a distal radius fracture, whenever a distal radius or any fracture occurs, there are always two forms of hematoma. There is the subperiosteal hematoma and a subcutaneous hematoma. So the subcutaneous hematoma does not have that much of value in reducing the pain after a hematoma block. So if we see this ultrasound guided picture, we can see here a periosteal layer over the fracture. So we need to inject within the periosteal layer. Means actually we need to go within the fracture and inject the lignocaine within the subperiosteal hematoma. This area it acts by desensitizing the nerves which cause pain in this fracture, and thereby it elevates pain. So we need a 10 ml syringe, a drawing up needle, and a separate needle, either a 24 or a 26 gauge needle for the injection. And some centers, they do use an ultrasound for this procedure. So the patient can be positioned supine with forearm kept on a support on a flat surface. We should know the dosage of this local anesthetics which we use. It is usually in the form of odd numbers 3, 5, and 7. It is 3 mg per kg for bupivacaine, 5 mg per kg for lignocaine, and 7 mg per kg for lignocaine with adrenaline. So the maximum doses of which can cause complications should be known. So ideally 10 to 15 ml of 1% lignocaine is ideal, or 5 to 10 ml of 2% lignocaine for an adult is enough. The procedure should be done under standard sterile precautions with appropriate prepping and draping with a no-touch technique. We should review the fracture, noting the dorsal pattern and location of the fractured periosteum. Once we palpate the fracture or the just proximal to the fracture, our finger usually slips between the third and the fourth compartment of that area. And once we inject the needle in it, we can verify the needle by confirming by aspirating the fracture hematoma with a flashback of blood, or we can confirm it under CAM guidance. Once the needle is confirmed, we can inject it with 10 to 15 ml of lignocaine after aspiration of blood at the fracture site. Most important point is that after injecting a lignocaine, we need to wait for at least 10 minutes before attempt of any reduction. We need to check that the pain has subsided. There are potential complications of this technique. The most common complication is failure. Many patients do not get effective analgesia, and it sometimes is because of inappropriate technique. There can be neurovascular injury by penetration of the needle volarly within the radial artery or some nerves. Infection is a side effect of this procedure, and too much injection of a local anesthetic can result in compartment syndrome. So there are some specific tips for this procedure, and most common error is to perform the reduction as soon as the lignocaine is injected. So ideally we need to wait for 5 to 10 minutes. Ultrasound guided is recommended usually in multifragmented fractures where we cannot palpate or where there is too much of swelling. If the injury is several hours old, hematoma may not be aspirated. That should be kept in mind, and the position of the needle should be verified. The analgesia with lignocaine alone may last for several hours, and the patient may not need any analgesia further. So this is what about hematoma block. Thank you. I would like to thank.
Thank you very much. I would like to invite any questions, or if I would like to know if any other faculty members are using hematoma blocks in the OPD.
Yes, sometimes we do use, but what is very important is to not to allow this lignocaine to go to the cerebral circulation. We apply tourniquet for about 5 to 10 minutes, and I ask the patient that you have to bear it. So till the lignocaine is organized there, it doesn't go into general circulation so fast. And very important, which one case I had a problem was when there was a abrasions. So when there is abrasions and patient has come after 1 or 2 days, there are chances of local infection. In those cases, there is hyperemia already because of the fracture as well as because of the impending infection. With that hyperemia, there are chances of absorption of lignocaine into general circulation very fast. So we have to be careful for that.
Thank you very much, sir. I think we can have questions at a later time after these 3 talks. Yes, Dr. Yogesh has a question.
Yogesh, you are muted.
Yeah, Dr. Lokhande?
Yes, sir.
With all the necessary precautions and getting ready in the OT with all the IV lines set up in a OR setup, do you recommend giving a local anesthesia exactly subperiosteally at the fracture site by the use of a CAM? Do you use a CAM?
If we have a CAM, because with that we can locate the needle exactly.
Yeah.
And I do some percutaneous pinning in this hematoma blocks. After giving this block, I actually infiltrate the area where we need to insert the pins, and they can easily be put in this hematoma.
All right, that's wonderful. Yeah, Harjot, over to you.
I would like to invite Dr. Gadge sir for his presentation. Sir, please share your presentation.
Okay. Hello.
Yes, sir.
Yeah,
the
we can hear you,
presentation is live.
Is it now visible and audible?
Yeah.
Yes, sir.
Okay. I'm going to talk to you on conservative management of the fracture of the distal end radius. Actually, this comes to 15 to 16% of all the fractures any orthopedic surgeon is treating is the fracture of the distal end of the radius. But in these 20 to 25 years, lot of revolution has occurred about the treatment and its management. And it has occurred because of the force of the trauma or the direction of the trauma and high velocity injuries. But at the same time, newer modalities or newer implants which are available. There is the mini implant sets which are available, because of which most of the surgeons are moving towards the this operative management. Here I'm going to cover the conservative management, and basically I'm going to talk about non-articular fractures. This is the very common injuries. As I have said, 60% of the fractures treated by the orthopedic surgeon. In the elderly, there are usually the extra-articular fracture, but in the young patients, there is the intra-articular fracture because they are high-velocity injuries. It may involve the articular surface, and usually it results due to the fall on the outstretched hand. The diagnosis is done by the history of the fall and similarly by examination of the wrist, hand, and the forearm. There is acute shortening of the radius. Movements of the hand and the wrist are very painful. The diagnostics test, that is examination and evaluation of the injured joint, radiograph of the forearm with the wrist in the AP, lateral, and oblique view. CT scan is indicated in many cases where you have to see the lot of comminution and the displacement of the fracture fragment has to be judged. The goal of the treatment is to preserve the hand and the wrist function, realign normal osseous anatomy, promote bone healing, and allow early finger and elbow movements. While doing a conservative line of treatment, you have to consider some important points, important measurements. One is the distal radio-ulnar joint congruity can be seen by the following measurements. One is the palmar tilt. Normal range of the palmar tilt is 11 to 12 degree. On the two lateral view, a line is drawn connecting the most distal points of the volar and the dorsal lips of the radius. The volar and the palmar tilt is the angle created with the line drawn perpendicular to the long axis of the radius. Then you have to see for the radial length. The normal range of the radial length is 10 to 12 millimeter. It is calculated on the AP view radiograph. This is the distance between one line perpendicular to the long axis of the radius passing through the distal tip of the radius styloid, and the second line intersects the distal articular surface of the ulnar head. Then you have to see for the ulnar variance. This normal ulnar variance is from 0 to 2 millimeter. This is calculated from AP X-ray of the contralateral or a normal side. Now the next one is the radial inclination. This is very important. And this normal range is 20 to 23 degree. This radial inclination is calculated on the AP view. The radius inclines towards the ulna. This is measured by an angle between the line drawn from the tip of the radial styloid to the medial corner of the articular surface of the radius, and a line drawn perpendicular to the long axis of the radius. This is the radial inclination, which has to be considered very carefully while you are doing a close reduction. Then a carpal malalignment, that is the articulation of the carpals with the lower end of the radius and ulna. There are so many classifications are available. That is the Guideline classification, Frickman's classification, AO, Malon, and the Fernandez classification. Some classifications are depends upon the anatomical position of the fracture fragments, and some are depends upon the mechanism of the injury. I don't want to go into the details, but the basic classification of the fracture of the distal end of the radius is extra-articular and the intra-articular. The extra-articular is a Colles fracture, which is most common. As you know, the distal fragment is displaced dorsally and radially, whereas the Smith fracture is exactly the reverse of the Colles fracture. The intra-articular fractures, volar Barton, dorsal Barton. In the volar Barton, it's an intra-articular fracture where the displacement of the wrist is volary or anteriorly along with the piece of the bone of the distal end of the radius. In the dorsal Barton, there is the intra-articular fracture where is the distal part, the wrist is displaced dorsally along with a piece of the bone of the distal end of the radius. This is an algorithm for about the treatment pattern of the fracture of the lower end of the radius. Fractures of the distal radius is basically divided into non-displaced and displaced. The non-displaced fractures are treated by the various splints or the plaster, and a regular follow-up is done. In the displaced fracture, there you have to decide which are the reducible and which are the unreducible. The reducible fracture, it can be extra-articular or the intra-articular. In the reducible fracture, the close reduction is tried under anesthesia. A regular follow-up is done every week or 2 weeks. The X-rays are done, but some of the fractures may get displaced as the swelling subsides. In these situations, you have to go for operative management. Then another class is irreducible, which you know that you will not be able to reduce it, or even if you reduce it, it is not stable. The straight way you have to proceed for operative management. Various operative modalities you very well know. There are the external fixator, then K-wire fixations, and open reduction and plate fixations. Now, what is the indication for the close treatment? Where there is a low energy fracture, low demanding patient, medical comorbidities are there, and minimal displacement or the acceptable alignment is there. You know, what are the indications for instability? When there is a greater than 2 millimeter of the articular step off, more than 10 degree of the dorsal tilt, less than 165 degree of the radial inclination, loss of the radial height, which is more than 5 millimeter, intra-articular comminution, irreducible fracture, and loss of the reduction after you attempted it. The close treatment of the distal end of the radius fracture, the main aim is to obtaining and then maintaining as an acceptable reduction. What is the meaning of the acceptable reduction? The radial length, it should be within 2 to 3 millimeter of the contralateral wrist, and it should not be too less than that. The palmar tilt, neutral palmar tilt is to be maintained. Intra-articular step up should be less than 2 millimeter. Radial angle should be less than 5 degree loss, and carpal malalignment should be absent. Now, the technique of the close reduction, the anesthesia, just now Dr. Lokhande has said the hematoma block, but hematoma block is possible only if the patient comes to you within 24 to 48 hours. Otherwise, you have to go for the intravenous anesthesia or a bias block. Then that is the technique. The traction is given by manual reduction. If the fragment is impacted, the first step is to disimpact the fracture. It may be necessary to increase the dorsal angulation. Then with the traction, distal fragment is pushed down distally and brought in the line of a proximal fragment. If the fragment is not impacted, a longitudinal traction is applied. Manual traction should be maintained until the application of the cast and cast has settled down. The basic principle. Now here, how to apply the cast? The assistant holds the thumb fully extended with one hand. The other hand holds the radial 2-3 fingers, maintaining a slight traction with ulnar deviation at the wrist. This maneuver is calculated when the hand is put in the prone position in case of the Colles fracture. The distal perfusion should always be observed during the whole procedure. In most of the cases, the cast is maintained for 4 to 6 weeks. In fractures which have significant displacement, even well reduced in the cast, there is a significant risk of subsequent displacement, and they should be monitored carefully with the radiograph. Now, pulse of the plaster application. The joints at each end of the plaster should be free and be able to move during the course of plaster. Avoid extending the cast too close to the elbow so that the person should be able to have a proper elbow movements. Pay particular attention to see that it should not go beyond the metacarpophalangeal joint. It should be only up to the distal crease of the palm so that the MP joint is free and patient is able to do the finger movements properly. Otherwise, it will cause capsular contracture of the MP joints. These are some various X-rays which are reducible fractures, which are reduced and then a plaster is given. This is another X-ray, fracture lower where the radial collapse is there, which is radial length is very much reduced. Radial length is achieved and a plaster is given. This is the position of the plaster where the complete ball of the thumb is open and metacarpophalangeal joints are free for movements. This is a technique. This is the patient is kept on the operating table with, if there is no assistant to give a counter-traction, then there is a wooden block which is there, which acts as a counter-traction. Another assistant is giving a traction with the is sitting, you have to give little palmar flexion and ulnar deviation. You can see I am giving a palmar flexion while the assistant is maintaining the proper force. The after treatment, watch for the median nerve injury symptoms. Paresthesia is common but should diminish over the few hours. Follow-up X-rays are needed 1 to 2 weeks to evaluate any displacement or there is a reduction is lost. The complication, the most common complication is a malunion. Non-union is there, but it's rare. Rupture of the extensor tendon, extensor pollicis longus tendon is sometimes observed. Median nerve injury, the complex regional pain syndrome, then the distal radioulnar joint instability, Sudex dystrophy, and shoulder hand syndrome are the late complications. Thank you. Thanks for the patience.
Thank you very much, sir, for an elaborative talk. Now I would like to invite Dr. Mukhi sir to present his talk on distal radius fractures. Then we will have the questions together at the end.
Thank you, sir. I thank Dr. Chandakji, Dr. Tanna, my teacher, respected teacher, and all my colleagues for allowing me to give this presentation. At the outset, I must say my job is made easier by my previous speakers. They explained to you everything. And see, this technique of close reduction and K-wire fixation is not new. It has been there for last so many years. And we have been practicing in institutes as well as private. And we have seen very good results for collisis fractures. But for the various Barton type fractures, intra-articular fractures, this technique is not that good. I must thank my colleague, Dr. Anil Kumar Vardarajan, Vidyadharan, for presenting some of the X-rays. And I will give you just a little thought of the cases which I have done. You see, the stability can be achieved by crossing the K-wires. That is one important thing. And I use 2 K-wires for the radius, and I do the interfragment fixation and see that there is no drudge. I've seen people doing plating, leaving the closure to the assistant and going away. And there is 10 to 15% even drudge after plating. And this test of testing the piano sign should be done in all the cases. I will just give you some of my innovative thoughts and how I do it. This is a case 1. This is a volar Barton fracture. He was advised plating and he was not willing for the plate. And he came to me and he said that I want to get it done, but I don't like the plate because it will involve a scar. Second thing was that it will lead to removal of the plate and all these things. And can you help me out? I said, I will try. And this is what I did. Anybody can comment on this. This, to my mind, was closed. And I got a good reduction. The drudge wasn't there. And I passed the drudge wire either through the lower end of the radius transversely, or see that this wire projects out both sides because sometimes it tends to break. And this was his result. And there is no scar. If I can show you his hand, you see it. I was surprised. Volar Barton, anywhere in the literature, you see there is no scar. Only the pin marks you can see. I was surprised. Next case. Yes, again volar Barton. Plating, he says, I don't want. I've seen the complications of plates. So I decided to do pinning. I got the reduction. I did the pinning. But this I had to do minimal opening. And which I did it. And you see the result. From then onwards, believe me, that I'm not using plates for volar Barton, dorsal Barton, or for that matter, distal end of the radius. I always give them a trial of close reduction and pinning. And whenever I have to open, then I make it a point to do a release of the carpal tunnel. So there are no issues of infection, 15% complication rates with plates, screw impingement, plate impingement, leading to tendon ruptures, and nobody takes the skyline view of the distal radius while operating. And you have to see that you take that the screw is not coming out in any of the views. This is a case C. I don't say that the pinning doesn't give problem. Sometimes it does. And this case was given by courtesy Dr. Anil Kumar Vardarajan. He presented at the AAOS. A marvelous thing. And you see what he did. And this is case 4. The pinning did give a bad result because this patient did not follow up. He went to Dubai and forgot about it. They removed the pins, they removed the cast and everything, and he landed up with the malunion. So we had to do reconstructive procedure, and we lengthened, we did the plating, we did ulnar shortening, and these are correctable things. So just give a thought, right? After removal, and you see the result. This is a malunion. It's not that you can't give the result later on. You can always. And he has come for multiple other reasons back to me from Dubai saying that a marvelous job has been done. So this is the post-operative. You do not give a cast. You can give them a splint and they start writing. There's no pain or mild pain. And the results are evaluated in the literature as well as in the AAOS. That even Jupiter
less active might say, I don't want to have surgery. I want to just cast it. I don't care if it's this looks crooked. And the evidence that are being accumulated would suggest that there's a good chance that that patient function very well. Many years ago, I co-authored a textbook on distal radius fractures.
This person's video, just play.
Older age that are less active might say, I don't want to have surgery. I want to just have a cast. I don't care. And the evidence that are being accumulated would suggest that there's a good chance that that patient will function very well. Many years ago, I co-authored a textbook on distal radius fractures. It was a whole book about almost 400 pages on distal radius fractures. My chairman of my department, Henry Macon, wrote a foreword, and he started it by saying, this is a very nice book, but I don't know why there's a whole book on this fracture. This one fracture where I thought that it's...
So the audio is not very clear. So can you just brief the message?
The message is that even Jupiter has admitted that close reduction and pinning in patients above the age of 65 is the method of choice. And that is a novel method of close reduction. I just want to give an insight that please go to the video and go to the India Today, or rather Orthopaedics Today, and see what Jupiter has to say on plating. Just don't keep on doing plating. That is my request. I thank you.
Thank you very much, sir, for very good cases.
Now we have cases from Dr. Jetwa, sir, and Dr. Farke, sir.
Yes, sir.
Any criticism and comment from Dr. Tanna, sir, or Jetwa, sir?
Well, it's very good, and you have increased the confidence of Waller-Barton. You see, for Waller-Barton, if the styloid process region is intact, from where you can pass. So I had also an occasion of passing in 2 cases where it was a very good radial styloid process side, where I had a good hold of the K-wire. And I also have developed a technique which is I have named as a reduction block technique, which is an extension of Kappanji technique. So sometimes I'll talk about that how you beautifully can do K-wiring of some of the, but important point in a conservative management, which I wanted to say, was this type of milking of the fracture. So when you give a traction, then with a 2 palm, you try to milk the distal end of the radius, by which you are going to regain the breadth of the radius. Because sometimes breadth of the radius is not possible when you go for conservative management. So that is something which we do, and it gives a sort of a good reduction. And it is really impressive that you have shown. And one more thing which Jesse Jupiter said, that I would not like to have plate in my arm, my wrist. That is something, phenomenal statement. Yes.
So is casting
Mukhi sir, Arjot, Mukhi
yes,
sir,
go ahead, sir.
Mukhi sir, nice presentation. You are always innovative. But one thing I want to ask you, when there is a combination in the wholer fracture also, there is a stability is in question. Axial migration of the fragment may occur in K-wire. In such a situation, how do you prevent it? By K-wire technique, because they are smooth cylinders and there is no support proximally and distally like external fixator or some pin holder. So if axial migration, how to prevent it of the
You
fragment?
can go for the Kappanji technique. Go to the fracture site. You pass it, engage the distal part, and then bend it. Then it won't migrate. So these are all the tips and the tricks. Open a little bit. Don't hesitate.
But in a Waller-Barton, Kappadanchi doesn't come. Kappadanchi comes into the dorsal angulation.
You can use it in Waller also. Why can't you use it?
No.
But it suggests the same technique Wallerly.
Yeah.
No, I think it is when you say a Waller-Barton, it is a split fracture and which has been come out. It is never going to be a full transverse fracture which you can do Kappadanchi into the dorsal angulation. That when you say a Waller-Barton, It's not a complete lower end of the radius which has gone down.
No, it's only the lunate part or even the radial part. There are two segments. You can put the K wires and you try doing it. I'm telling you.
So most of us would like, and as the current literature says, that volar shear fractures, you need a good buttress anteriorly, which is a very efficient, easy treatment. But as Dr. Jawahar Jetwa said, if there is a radial styloid attached to the volar fragment, shear fragment, then only possibly this could be achieved.
Yes.
But then the problem of radial nerve or the cutaneous nerve and the radial artery would be there. So for most of the surgeons, I think a volar plate works very well for volar shear fracture, is what most of the surgeons would be doing. I don't know. Your expertise is there. You have treated a lot of these cases and shown these cases. Occasionally for us, yes, but most of the surgeons would like to treat this with volar plate.
Plating.
I think only Mukhi sir, when the fracture is very much reducible and you are able to pin it proximal as well as the distal fragment together, in that case it is possible. Otherwise, majority you cannot treat by this method. And I think the choice of treatment would be a anti-glide plate. That should be the message should be given.
Okay.
And the intra-articular portion, it will remain like that. You cannot have a proper alignment in the intra-articular region just by putting the K wires.
Okay, sir, what is your opinion on volar shear fractures? You are muted. Farke sir, you are muted.
Yeah, okay.
Yeah.
Yeah, I always, almost 99% of the times I do plating because it gives good results in my hand. And I am scared of putting KYs through the volar surface of the radius. Dr. Mukhi gets very good results, but I don't have his skills.
No, it's not the skills. I tell you, it is the courage. I tell my what you call my students or my colleagues that you do a plate, and they do it and show me that no, I managed it with K wires. Honestly, I'm telling you.
Yeah, you
my robots.
But
my robots, they do it with the pin. I just tell him go lateral to the palmaris longus, ulnar side of palmaris longus. That's all.
Okay.
I'm still scared.
Harjot, we move for the remaining
I
two.
think we can have the cases now, and we will have a few questions at the end.
Yeah.
So I would like to invite Dr. Jawahar Jetwa sir for his cases.
And then Dr. Ajit Farke
Your
sir.
screen.
Yeah.
I do not have cases basically, but I am going to show one case and one slide of the another case.
Yeah.
Sure, sir.
So I am very much thankful to this group and Dr. Chandak and Gadigone sir that you have given me this opportunity to talk about the non-operative management of distal radius fracture, where this case is particularly a volar barton. So I'm going to talk about that. How do I do without operation? The patient was 62-year-old. We're having a less amount of remodeling. He had a fall from two-wheeler. He reported within an hour, so he came very fast. It was a close injury. It was right side because it's a domination side. He had diabetes. He had hypertensive. And by profession, he is a chartered accountant, so who understands everything very well. And this was about the patient. And then regarding the fracture, he came to my clinic with a nearby X-ray where he has taken this, and then he showed me this particular X-ray. And he had minimum pain because I could see from CCTV camera that he's waiting in the waiting room without much of the pain or sort of that gesture where he wants to hurry up, do something very fast. And he said that I do not want operation. And I have selected you because of your seniority and your skill of non-operative management. So on one side, there is a high demand from the patient that you do everything, whatever you want to do without surgery. And then the injury was, there was a distal end fracture and it was intra-articular there was a little volar subluxation, which was a very worrisome when you get a volar Barton fracture. And of course, there was an intact ulna. So I thought that what could be my next steps and plan, because he's demanding non-operation. So I thought, let me investigate further so that I can tell him that what is the amount of injury he's suffering from. Then I try to classify the fracture. Then I go to AO book for classification or refer books or go for the literature that has anybody done a volar Barton without surgery. And then I need to counsel the patient that this is what is going to happen. I reduce, apply SLAB, then I check, apply circular cast, then I remove the cast by 5 to 6 weeks. And then I need to be on to after treatment for the best recovery. Because in surgery, you may forget, but in conservative, you have to be very careful for multiple follow-ups. So this is what I thought about my plan. So what I did, I asked him to go for a 3D CT scan, and we can see there is a split, there is some combination. At the lunate level, things are not very bad. But at the scaffold level, yes, there is some sort of a dye punch or some sort of a deficiency of the articular region. So I got all these things, and I also took these sections where I could see that there is some volar migration, there is some combination, and radial steroid is not much displaced, but yes, it is a big one, which is there. And then I also go for a 3D CT scan where I could tell him that this is a horrible thing and why don't you go for operation? Conservatively might give some problem. But then he said, no, whatever happens, I am ready. But I know that you are going to give me best of the result. And then I just checked the radiological report. Now, interestingly, we talked a lot about STAP. But in radiology, even with the 3D CT scan, they are not going to talk about the STAP. They may say about the gap, but the STAP they usually do not report. And a fortunate thing was that it was an intact distal ulna. So I tried to classify this fracture. So I went into literature. I go through this app, which is an AO classification. And I found that this is classified like 2R3B3.3. And it's a volar ring, which is called reverse Barton, or sometimes it's called Geyer and Smith type 2. So that is what I did some survey. Then I found one, sort of a suggestion in the book that cast treatment is for what? Usually we refer AO book only for the operative part, but everywhere AO has given a non-operative part also. So you better find out that what is the non-operative options they have recommended. And with the other books, I found that when it is undisplaced or minimally displaced, it's a low demand patient, which is very, very important, which has been discussed so many times with other speakers, that you try to find out patient is happy with whatever is minor, deformity which remains. You need to exclude unstable pattern. You need to have obtain a good reduction. Then meticulous casting technique is very, very important. I have a whole 40 minutes lecture on the casting and also the complication of casting, where there are so many things which you have to now, which has been developed in a minor aspect of a meticulous casting. Do not immobilize in extreme of the position. Extreme of the flexion or extreme of the extension is going to give so many trouble, and you need to have a sincere, careful follow-ups. And then this was one reference which I found out in literature where he treated 23 cases of volar Barton, and he followed up from 7 to 70 months, a long follow-up. And there were only out of 23, 11 were satisfactory, around half of them. But very interesting that out of those 11 satisfactory outcome, 5 were without subluxation, but 6 were with the subluxation. So that has given me some sort of a courage that why not to do this patient with a plaster. And the paper said that quality of reduction influenced the outcome very much, and articular steps should not be less, should be less than 2 mm after reduction. That was this recommendation. So what did I do? I counseled the patient. And I counseled for what? I asked him very much that there are possible outcomes, complications, there are possible common complications, there are possible rare complications, and I need to explain everything before SLAB application, before circular cast, and during rehabilitation. So every time I have to remind him, say, I had told you to go for a plate, but it is what has happened. And every time I try to tell them, this is what is in the literature and what is going on. So counseling was very important. So what I did, I reduced in a extension of the wrist. Only then I was able to get a good reduction. And so I applied a pressure on the volar side like this and on the dorsal side like this. And then the plaster was given. Unfortunately, he lost the x-rays, but he sent me one picture where he was celebrating with his grandson his birthday, and with the same cast, he was so comfortable. And then, as usual, follow-up, circular cast was given after 4 days when the edema was not much. Cast was removed after 5 weeks. Home exercise were instructed, followed up for 4 months. Patient was very happy. I am also very happy. Incidentally, he is a chartered accountant for me. So he is submitting my all income tax returns right from my beginning of practice. So he remains in touch with me, but he never ever uttered about any problem. So I thought whether he is a fine or he is just accepting whatever is happening. But at one day, I just asked him, why not to see what is happening? So at the end of 4 years, I just asked him to come back. And this was the X-ray. Look at how wonderfully nature has done. And I could see that it is a wonderful remodeling which has occurred at the age of 62 years. So, and then I thought, why not now compare? So this was on right side, affected side, and this was on the left side. And you can see beautifully how this volar button has come into its place in a lateral position, I mean lateral x-rays. Almost it is similar to what is on the right side and what is on the left side. So this is how it works. And so it was a radiologically very good outcome. And functionally at the end of 4 years, naturally he had a full pronation, full supination, full extension, full flexion of the wrist. So this was something very important to understand that this is possible. There is another example where similarly distal end of radius fracture, where I reduced under IITV and I applied a very good cast. The cast has to be where there is a good distal movement. That is what we wanted after plate. We wanted early mobilization. So if you can reduce it and give early mobilization, it is similar to plating. But this is how patient had a full free movement. And this is very important to see that you give a proper cast and try to see that he has a very good elbow flexion as well as all movements of the fingers. And this is what has happened at the end. And she had a full movement at the end of 4 months. And I am yet to go for a full follow-up, a long follow-up. So my point of presenting this was there are some lessons. Number one, you need to investigate fully and see the possibility whether you can go for a conservative management. Second, exclude unstable variety if you are not able to get a good reduction. Counsel well and inform consent even for non-operative. When you go not for operation, please take a 100% signature on the consent form that this has been explained fully, because this is the time where you are not sending the patient into operation theater yet. You need to have an informed consent and you go on reminding them multiple times. Achieve best possible reduction, apply best cast technique, remove cast in time. Do not wait and do careful checks during rehabilitation. So I thank you very much for this opportunity. This is what I just wanted to convey to you people. Thank you.
Jawahar, can I request you?
Yes, sir.
Can you go back to those x-rays?
The last one or the first one?
First, chartered accountant, first x-ray and last x-ray, which you
Yes.
in comparison.
Yes, sir.
Pre-operative.
Yes, preoperative is left side. I mean, preoperative, okay. I'll just go back. This is preoperative.
The picture which is taken
Yes.
in this pre-operative,
Yes.
it is the typical where the soft tissue hinge is intact.
Okay.
This soft tissue hinge is intact. This is not going to displace. Your lateral view which you have taken here in the pre-operatively,
Yes.
the ulna is going out.
Yes.
It's seen out.
Yes.
While in the post-operative one, ulna and radius are into one direction. It is that small rotation which you have taken, which
Yes,
is giving you a better picture radiology.
This is an undisplaced fracture where soft tissue hinge is perfect. It is not affected much. So that's the one which will give you a good result.
Okay, sir.
Whether you treat them, you don't treat them, whether you give them a plaster or you can give them an ordinary splint, which comes ready-made splint, which you give it.
Yes, sir.
Same thing is in your next pen. Can you also show the next one? Other case which you have shown. This one. Now here also, as you can see, it is a one typical, there are displacement which have been described, posterior tilt and a posterior subluxation. This is the typical which comes into posterior tilt. So that the dorsal soft tissue hinge is intact. It is not displaced posteriorly, it is only angulated posteriorly. This you can reduce it. Soft tissue hinge is very good. So it will remain into the good position. It is not likely to get displaced again, but once you reduce it and you give a plaster. And you treated them beautifully into the minimal extension so that the finger movements and everything which has been made.
Yes.
So it is what is the message is basically that when you give a plaster, don't give it in this position.
Yes.
You can't give it in this position. It has to be in a minimal dorsiflexion where you are going to get the full wrist movement. And these are the ones where the soft tissue hinge is normal. As you can see, it is perfectly reduced because once you flex it, it is going to get reduced.
The only thing is, sir, that we want ulnar deviation for which we have to extend the plaster over the first metacarpal because then only you can give that sort of a push. So instead of keeping the whole thumb out of the plaster, we have to give some sort of.
Sorry, Jawahar. In order to give an ulnar deviation to the fracture,
yes,
initial ulnar deviation is only at the carpometacarpal or intercarpal joints. In order to give it to the fracture, you will have to really go to the extreme position, which is going to be very uncomfortable.
That is true, but we are not doing it that way. I mean, we are pushing the radial border towards ulna and we are getting a good result. But if you keep it a little bit more away, then there are chances. But yes, it is a stable variety. Ligamentotexis works in a big way.
I am endorsing your treatment because this is the one classical one in which conservative treatment is going to work. And now if you go back to the final X-ray of this.
Yes.
Now you can see the final X-ray. There is a collapse. There is a ulnar variation, ulnar variant is gone. There is you can see this typical way you're seeing the ulna into this dead lateral position or whatever it is. And you can see the ulna is more prominent, which you can see it very well. But this still gives you an excellent function, which
yes,
you
sir.
do it so beautifully.
Yes. Thank you, sir. Thank you.
Thank you very much for pointing that out, sir. Vijayanan wants to comment and then Mukesh, sir. Then we go to next case.
Yes, sir. The same to Dr. Jetwa, sir. It was very good presentation. Just, sir, as opposed to Dr. Tanna, sir, in the first case of volar button, it's not just the soft tissue hinge. It's the bony hinge on the volar side is also intact. So it's just like a split type of volar button. That's why it got a good result. If the bony bridge would have been lost, then it subluxates. Otherwise, it does not subluxate.
My point is that one should every time do a hyper extension of the wrist and check whether it is reducible or not in a all volar button. It is an extension of the wrist and all those maneuvers which will give you some idea before putting an incision. And that may allow you to go for a minimal invasive or rather conservative management.
Dr. Mukhi, you wanted to point out something?
Yeah, just the last X-ray lateral view. Is there any drudge in that? Just show it, please, Jetwaji.
I think it's a rotation issue.
Yes, drudge is not there because patient is happy. That is the point.
No. Many times, even with drudge, these people are. This is the thing which I want to point out.
No, that you had talked about the piano sign.
Yeah.
But that sometimes in this special patient I had no such piano sign, but Tanna sir said that it is a rotational sort of, you are not able to get the exit view. So sometimes rotational view also show like
this
this.
is a dead lateral view here. And you see the ulnar styloid. And this much of displacement is 100% right.
Maybe on X-ray, but not clinically.
And why didn't you put a K-wire?
Well, this is again a patient of COVID where we wanted no operation theater procedure. This is exactly in month of April, which I did. And, you know, there are some limitations for which you have to go for conservative management.
So thank you very much for sharing those cases. So we have understood the art of conservative management and the problems associated with conservative management. Dr. Farke sir, can you share your screen? And after that, Dr. Negi, and then we'll have a discussion. Farke sir, can you share your screen? Yeah.
Okay, I got a very short talk because there's nothing much to discuss about conservative treatment of fracture clavicle. It is something that all of us keep on doing routinely every day, and there's hardly any skill involved in this except the skill of talking with the patient.
That is what needs to be done.
It is common, short, it's one of the commonest factors in adults, and incidence of male is more than females. Mechanism of injury is usually due to a high energy trauma in the young and a low energy trauma or fall in the elderly. Now, why this controversy of conservative and operative treatment has increased now is because we are getting more and more patients with high energy trauma in the younger age due to motorcycle accidents. And these patients have a lot of displacement. They have complications also, and they might require surgery more frequently than the the other group of the low energy trauma or fall on outstretched hand. Now, classification is very easy. The middle third is type 1, and this is the one which we are going to discuss more. Type 2 is lateral 1/3, and type 3 is medial 1/3. Now, lateral 1/3 is again divided into two. One is over here, that is lateral to the conoid and trapezoid ligament. This fracture will be undisplaced, and this fracture does not require any surgery. Whereas if it is medial to or situated in the ligamentous region, then the displacement is more, and these patients are more likely to require surgery. Now, whether to fix or not, so conservative treatment is the norm, or should be the norm, because almost 90% of the patients can be managed conservatively. Undisplaced fractures, obviously, you can manage conservatively. Also, lateral 1/3 beyond the coracoclavicular ligaments, and displaced fractures with less than 2.5 centimeters of separation. These are the three classical indications for conservative treatment. There is a very low rate of non-union. There is 0.03% to 5.9%, according to various available literature. And often non-unions are also asymptomatic. So the X-ray might show non-union, but the patient doesn't have any problems. Now, whether to fix or not, now you can see an increased tendency to advocate surgery. When I was doing my post-graduation in '83, at that time we almost never talked about opening a fractured clavicle or fixing a fractured clavicle. But now we see more and more patients being advised surgery by surgeons. Why this has happened is because many recent studies show up to 15% non-union, and that is probably because of the increased amount of trauma that the patients undergo during a motor vehicle accident. More and more studies showing better results with surgery. Previously, the available devices were not so good. We had only a reconstruction plate or a DCP. But now we have got locking plates and TENS, which gives better results than the non-locking plates. And probably there are more orthopedic surgeons who have spare time. So they can convince the patient that, no, you have got problems and you require surgery. Once the patient is convinced, your job is easy. So I went back to the Cochrane review to find out what the world literature says about this. about surgical versus conservative interventions for treating fractures of middle third of clavicle, which is the subject. And this is a recent publication, that is 2019. So it's a recent review. So they say that you have to consider the balance with the risk between the individual outcomes, because surgery might give better cosmetic results, but the scar may be unsightly. Also, adverse surgical events, including wound infection and dehiscence, hardware irritation, and again another surgery to remove the hardware. These may counterbalance the advantages that surgery has. So they finally say that treatment options must be chosen on individual patient basis after careful consideration of relative benefits and harms of intervention and preferences of the patient. Now, which conservative intervention is better for clavicle fractures? There is a study about that also in 2016. They say that the current evidence available shows that there is no difference between the results of different types of conservative treatment. So whatever you do, the patient is going to have the same result. And surgical interventions, which surgical intervention is better for non-union or fresh fractures? So there is very limited or low quality evidence available from control studies. So each one touts his own method of fixation. Which conservative treatment should be done? There are two standard treatments that are advised, as a sling, that is a collar and cuff sling or a regular pouch arm sling, which is very comfortable for the patient and easy to apply. Patient has no problems about the treatment, or the figure of eight, either bandage or figure of eight splint, which is ready-made available. Now this is more frequently prescribed, but this has got more problems, because in this the patient might have problems with the skin in the axilla, or if it is tied too tightly, he might have neurovascular problems. So the one more way is to use both of them, to be doubly sure that you give a sling also and a figure of eight also. But this is rather overkill. You don't, a fracture does not require all this to be done. Now, how long is it to be kept? 4 to 6 weeks is the maximum. And movement should be started as soon as pain is less. This is important. Physiotherapy should be started after 4 weeks and pain medication as needed. One thing I'd like to stress in this is my personal choice is to use a figure of eight brace. But I tell the patient every day to remove the brace, take a bath, clean his armpits and reapply the brace. I don't tell them that you should not touch the brace for 4 weeks, because then by the time they come back, they smell so bad and nobody can stand near them. When is it contraindicated? So conservative treatment is contraindicated if it's a compound fracture, obviously. You have to do something about it. If there's a tenting of skin due to sharp medial fragment, because then the skin will ulcerate and the patient will have more problems. Or if there's a neurovascular compromise and you are planning to do some intervention for the neurovascular compromise. And relative contraindications are symptomatic non-unions. That is, if the patient has non-union which is symptomatic, then you have to operate. Separation or overriding more than 2.5 centimeters, because long-term studies have shown that 2.5 centimeters of shortening of the clavicle will give poor shoulder function. It will also give poor cosmetic result with the shoulder sagging down. And so cosmetic considerations are the last indications for this. Complications of conservative treatment are very common, because malunion almost invariably occurs. They never get perfect union, at least on X-rays. So if you are going to treat X-rays, or if the patient is going to follow X-rays, then he is never happy with your conservative treatment. But if you are treating the patient and not the X-ray, then it doesn't matter. Non-union might occur. It may be symptomatic or may be asymptomatic. And skin and occasional neurovascular problems might occur due to tight figure of eight brace. So what is the carry-home message? Because there's nothing much to discuss about clavicle fracture. Most clavicle fractures can be treated conservatively. Non-unions are not always asymptomatic, or not always symptomatic. So Even if there is a non-union, patient may not complain. And they are to be operated only if there are specific indications. I personally tend to avoid surgery, and I try to convince patients not to get operated because I really don't have time to operate on patients who have no indications for surgery. But if you have plenty of time, you can convince many patients to get operated, and the patients will also be happy because their X-rays will look very good. Thank you very much.
During conservative treatment, thank you for a good lecture.
Welcome.
During conservative treatment, do you take radiological reviews?
I take X-ray on day 1, and then I take a second X-ray after day 30, that is 1 month afterward. I don't even call them for follow-up unless they have any problems, because they just waste my time, and the X-ray keeps on looking the same for the next 6 months. So there is no sense in keeping on taking X-ray, or X-ray after application of brace, X-ray in lying down position, X-ray in sitting position. It doesn't make any difference. 99% of the patients never come for follow-up. Actually, Dr. C.N. Kulkarni and I had done a study on this 20 years back. That's 20 years back. And together we called 200 patients for follow-up 6 months after the fractured clavicle. And after 6 months, out of the 200 patients, only 3 patients came, and they only came because we had promised them a free X-ray. Nobody had symptoms. So no one has problems after 6 months.
That is absolutely perfect. Asim, you were waiting since long. I think we will hear you now. Can you share your screen? Asim sir, you are muted. Please unmute yourself and then share your screen. So this is the last presentation today, and then we'll have discussion. By the time he shares, yeah, he's ready.
Yeah, it's ready.
Yeah. Please.
Yeah.
Please proceed.
From beginning. There are 3 quick cases. We'll just go through them and then we can discuss. This lady came with a CT scan which wasn't really up to the mark, but done only 1 day back, was sent by my friend. This was the CT scan, around 42-year-old housewife, dominant hand. Her X-ray was even worse than this. So I had no guts to repeat the CT scan and make her spend more money. So I got a proper X-ray done. This was the fracture. We can presume the greater tuberosity is a separate fragment, and there is a very, very subcapital type of fracture there, and the metaphyseal part has invaginated into that. She already has been advised surgery by people. I had no intentions to operate on her, and she was put through a conservative treatment after explaining all the pros and cons. No consent was taken, which I learned in last 3 months, that conservative treatment also should require a proper explained informed consent, though we explain all the pros and cons. This is how she was at 10 weeks, and this is how she was at 6 months, and she had an absolutely normal function. So the conservative treatment for me is a immobilizer for about 4 weeks. I asked them to come for weekly X-rays for first 3 weeks, but hardly anybody comes at 7 days. They usually come at 10 days or so. So in first month, about 3 X-ray checkups, and they are explained every time that if position is really becoming bad to worse, then we may have to change our course of action and we'll operate. Passive mobilization, especially the external rotation part, starts around 3 weeks, but no active abduction. Around 6 weeks, active assisted exercises are prescribed and explained. SOS converted to surgery. So you need a patient who is very cooperative, who is willing to come for repeated follow-ups, gets X-rays as and when necessary, and is willing to undergo surgery if things they really do not turn out to be good. So second case will be stop share, and again we go to the second one. Here is the second patient.
Is there any specific physiotherapy protocol you follow at 2 weeks, 4 weeks, 6 weeks?
In first 6 weeks is mainly around 3 weeks. I am very much concerned about getting my external rotation. By that time, 3 weeks, 4 weeks, they can really externally rotate. And that is the thing which bothers them most. So,
by the time you share, Atul, there was a question for you. How do you control rotation in a supracondylar, which is very difficult to control, is what the delegate has asked.
Yeah, so rotation, I think the two things which are important is that you don't move the arm too much, you move the machine. So I think there is this earlier concept where we would rotate the forearm when you're doing a conservative treatment.
Yeah.
So I think once you do the, you get a reduction in AP with good traction, you got the fracture to length. Then you flex the elbow and you just take an internal and external oblique view. Look at the columns. If the columns are not displaced, then you're sure your lateral view will be good. So you never rotate the forearm full 90 degrees, otherwise you will lose the reduction. And you hyperflex it only for the reduction. You hyperflex up to 120 degrees. So you lock the fragments, keeping a hand in pronation or supination. Then I would take an oblique view with the IITV. So you don't need to change the IITV also. If you're not sure, then you tell the person to rotate the IITV. Don't move the arm. And that is typically for flexion fractures, not for extension. I think extension, a good oblique view, middle lateral, 30 degree oblique view, the columns are intact, you're almost 100% sure your lateral view will be good. Then you pin it and then take a lateral view by reducing the flexion.
Thank you. Thank you so much. Asim, we are able to share now?
Yes, sir. Yes, sir. I already shared it. I'm going to the first day.
Yeah, we are yet to see the screen.
No, it's the same one, I think. Yeah, it's the same one, yeah.
We are not able to see the screen. We are not
yeah.
No problem, no issues.
We haven't shared the screen, Asim.
Yes, sir.
But I think all those patients who are conservatively treated and they get excellent result, they are the best happy patients of all the lot.
Yes, sir. Slideshow and from Sydney. She is a radiologist, around 55-year-old. While exercising, she had a fall doing some yoga or something. And this was her X-ray. And you can see a double line here. And being a radiologist, a CT was very promptly done. These were the...
Double line you feel is pathological?
No. You had seen this patient. It was sent for your opinion also, sir. Both of us agreed that it is conserved. It's not pathological.
Yeah.
Then,
the double line is this.
That's the greater tuberosity.
Is the tuberosity, yeah. Which wasn't really much displaced, though it was there, slightly tilted, rotated, but not much displaced.
एकदम क्लियरिटी घूमते ऐसा
there was a lot of panic at second week when this X-ray was taken. Yet she persisted with the suggestion that we can still conserve, and if things really become bad, then at 4 weeks also it will become all right, this surgery. So you just hold on. And here she is at 5 weeks, back to job, and this is 6 months, and this is her function. She is absolutely normal, back to doing yoga, and she's very much into exercises. So absolutely normal function. And stop share. One more is there, which is almost 16-year follow-up.
The virus which was there in the second patient got remodeled, or it was just X-ray appearance?
I think it was more of a rotation, sir.
Okay.
More of rotation.
So I think those were really good cases. Harjot, we have a lot of questions on the chat box. I think Can you take up the question, Arjun?
Negi sir,
Yes, sir.
may I ask you one question?
Yes, sir.
Is it not that the 3-part and 2-part undisplaced fracture and
Yes.
their majority can be treated by conservative treatment, but with the advent of modern technology, are we not
Agreed, sir.
overdoing the surgery in this type of patients?
We are definitely overdoing, sir.
Why do you operate on these patients?
Yes.
Or undisplaced, the soft tissue hinge is
I don't operate.
Because majority they give a excellent result with conservative line of treatment.
As a matter of other way around, I'll go. If you plate this thing with the Philosopher's plate, you will have a marked stiffness of the shoulder joint.
Agreed, sir.
And all you want to treat, you treat it the way Chandok is doing it. Some put those towels around, and then probably then it is going to be all right. You get a good X-ray, but the result is going to be all right even without it.
I also have observed, sorry.
The real beauty of the conservative treatment is displaced fracture, you reduce it, and then you prove that you did not need a surgery. Then there is something in it. These are all undisplaced fractures which they are not going to get displaced at all. You can even put them into arm pouch or anything else.
They're treated by quacks.
Yeah.
Majority fractures are gravity. Gravity actually reduces the fracture and movements achieves the functional improvement.
Exactly.
And one more observation I have, that impacted fracture of proximal humerus is quite stable compared to impacted fracture of transcervical femur, because even gravity will not disimpact it. So impacted fracture which is not now moving is always a good thing to go for conservative management.
No, but one point. Sir, it causes the impingement.
No,
that
impacted is inside the head. It's not outside.
Yeah, that trochanter gets impinged.
It's not like that it has override so much of the acromial region. But what Tanna sir said, that I have 2 cases where I have done reduction with the traction, and then I have gone for a conservative management. It is possible. It is possible. There are very few cases which can be done, but it's good. One must try it. And remodeling is so good. In an orthopedic in pediatric age of group, compared to remodeling capacity of any fracture across whole body, the highest remodeling is fracture neck humerus.
Vijayanand, you wanted to say something?
Or because of the callus which really hides everything, and you don't see the fracture site, because ultimately the callus forms all over.
Yes.
You don't see them.
Yes, sir.
Remodeling will actually in children. In adult, why is it going to be remodeled?
Yeah. Harjot, you had a bunch of questions. Please go on asking.
Yes, sir. There were a lot of questions, especially for Tanna sir and you, regarding distal radius fracture management. So Tanna sir, lots of questions for you regarding how do you manage a distal radius fracture? Do you prefer conservative treatment in young, or do you prefer conservative in elderly? Because someone was, even I was interested in your own case of collapse.
In a young patient like me, you can treat them conservatively.
Like yours, yes.
Yes.
Right.
I think basically now, on a serious note, young patient with the angulation, I think if you got to distinguish between the displacement and the angulation. If the fracture is only angulated, you can put it back and it will remain stable. But if the fracture is angulated and displaced, now if you reduce it back also, the soft tissue hinge is gone. So that is the one which is going to get redisplaced, as we all know very well. After you can reduce almost every fracture anatomically on day 1, but they don't remain there because they get redisplaced. That is the reason why you need surgery. So if it is a fully displaced fracture areas, You need a conservative treatment if you want to do it. I feel that you reduce it, put in these 2 K wires, and that's going to be good enough in majority of the cases. I think by incidents like clavicle fracture, the operative treatment with the plating is more or less confined to about the Barton fracture, about the volar Barton fracture. But otherwise, I think the K wire you put in, 1 or 2 K wires, and you put in the plaster in a small extension, and even there is a small amount of malunion as it was shown by Jawar, is going to be perfectly all right. The K wire will not allow a redisplacement, and that's going to be good enough. It will still allow a little collapse. So the plating by itself may give you an early mobilization, so you have those 3 weeks of advantage. You say early mobilization, but no plating of the radius is going to really start moving it and start operating upon. So that also is going to take time.
KYS in both elderly and young patient if the displacement is there. Then do you recommend adding a JES over KYS?
But if there is a displacement, if you don't put a K wire, it is going to redisplace.
Do you advocate use of JES or external fixator along with KYS?
No, generally no. If at all, if it needs all that, that means there is a big comminution, then I go ahead and do a plating with the grafting.
And any difference in management of Smith fracture or Colles fracture, or both can be conserved?
So I think the Smith fracture, it is displaced Smith's fracture. It needs surgery for a good result. But the one which Jawar had shown, such fractures can be conserved because they are the ones which have been comparatively minimally displaced or soft tissue intact, and they are the ones which can be conserved without any major problem.
Then do you give above elbow or sugar tongue splint also, or only below elbow splint?
Elbow only. But as I said, small extension, no flexion. No flexion. It has to be a small extension. If you put in flexion, then you will never be able to get the range of movement, because even if you put the normal wrist into flexion, you can't really flex it. In order to flex it, you will have to go in extension.
Then dorsal slab on day 1 and then converting to cast, or directly cast on day 1?
So I put a full cast with a padded cast, which may have to be changed after about 10 days or so.
Okay, sir. Thank you, sir. So there is a question from Dr. Mohapatra, sir, for Dr. Jetwa regarding immobilization of the wrist in flexed position in volar Barton. Should it be in flexed position or in wrist extension?
It has to be in wrist extension because we want the volar to go back. So it has to be in extension. As Tanna sir said very well.
The only one which will reduce.
Yes.
Section is the one which is a Colles type of a fracture, which you want to put it like this for reduction.
Yes.
But you will compromise the flexion of the fingers.
And when you apply cast, do you prefer to apply synthetic material after a few days of slab?
So what I do is that I give a spiral splint to start with. It starts from the dorsal side and goes spirally to the thumb region. So that is a spiral slab which keeps good ulnar deviation, some dorsiflexion, some palmar, and initial for 4 days, and then I give cast. Very important point regarding the K wire is that once you have disimpacted a fracture of an elderly person, where there is some, after disimpaction, there is some minor gap. In those cases, when you put multiple K wires, do not remove before 8 weeks. For so many times collapse is because of removal of K wires little early, especially when it was an impacted, which you have disimpacted, and there is some sort of a gap, millimeter only, but that body requires more time to fill it up. So you have to wait for a little longer in those cases.
There is a last question with me for Dr. Samrat Tauri, sir. Sir, do you use thermoplastic material to make splints yourself? And another question is, in crush injuries of hand, what do you do for the fingertips after the wounds have healed? Any prosthesis or something like that?
Sir, you are muted. Please unmute yourself.
Okay, sorry. For the first question, I had thermoplastic splint with me, but it requires some other things also, water bath and other things. So I don't use it, and I'm happy with the Gypsona or like a plaster of Paris thing. If in a situation where I think that it will be a lot of soakage will be there, or the patient may not be able to comply with this, or I'll require a lot of straps on it, then I would temporarily do this and send the patient with complete prescription as I have described for splintage to the orthotist. That is one. For the fingertips, I mean, if there's a crush injury and the finger are lost, does that probably the question means that if the fingertips are lost, it's a very much a case-to-case merit basis thing. I mean, I didn't understand what is that meaning. Yes, okay. If it's about the artificial fingertips, then we give the patient the option about it. But the point is that they are asensate. So a patient may use it for some days, or maybe you maybe use it for function if he has to attend a function or something. But otherwise, generally, patient won't use the artificial fingertips. So if their other joints of the fingers are working well, then they won't prefer any artificial fingertips.
Thank you very much.
I don't know.
All right. There is one question, Harjot.
Yes, sir.
So this is for the distal and radius segment. What are the indications of passing a K wire from ulna to radius, the ulno-radial wire, just to prevent the collapse, or what is the indication? What is the thought process behind putting the K wire, and when do you decide that ulno-radial wire is essential? Anyone?
Basically to stabilize this distal radioulnar joint, which most of the time gets subluxated even you are treating conservatively. So just to stabilize that distal radioulnar joint, sometimes you are putting this K wire from ulnar to radius side.
No, in comminuted fractures, we often tend to use that the wire. So that's what we wanted to know. Any other?
Mukhi sir is using it commonly. Mukhi sir, you wanted to comment?
Yeah, I use it very commonly, and I don't want drudge. That's the main principle. And I have seen that even if it breaks, it can be pulled out from any end. So there's no harm. What's wrong in it? And it gives like an external fixator for the radius.
Okay.
Okay.
Yeah.
It also helps. It also helps in preventing collapse. Also, if you put
Very
a
much, yes,
wire like a wrapped wire, as you see in the upper condylar fracture, from the ulna obliquely to the subarticular surface in the radius towards the styloid process, and if you incorporate in plaster, probably it helps in preventing the collapse. So sometimes I do use in a sublaminar, subarticular K wire apart from inferior radioulnar joint stabilization.
And one more thing regarding drudge, there is no good literature available where you can take a dead lateral view of radius in full supination and dead lateral view of radius in a full pronation. And then what is the position of the ulna? It is something interesting when you look at in IITV. It is not the same lateral view of radius in full supination and lateral view of radius in full pronation. There is some movement of the ulna and you have to compare with the normal side.
Yes, a lot of interpretation is required in that. Yeah. Negi sir, can you please unshare your screen? Please unshare your screen.
Yes.
Yeah. So that we can have a discussion. And we had really wonderful
Sir,
extremity
Chandak sir.
Yeah.
May I ask one question?
Please go ahead.
Because in osteoporotic bone after conservative treatment, collapse is the rule. Still the patient do very well because of the functional good outcome. So can you call it as a functional malunion which is acceptable to the patient and does not require a further surgery in majority of the cases?
Yes. It is when the patient is less demanding and when there is osteoporosis, usually these patients, they accept this sort of malunion. But where there is a demands is more, very active patients, then you have to do the correction by doing any surgery for the lower end of radius, by doing osteotomy or by lengthening. But most of the patients we have seen, they come with the deformity and they are happy. But these are all patients who are the less demanding patients.
It's very
and they
difficult.
are usually the older patients, older age, more than 50, 60 years.
You must keep these patients on vitamin C, vitamin D, and PTH. You give them PTH, the results are fantastic.
But sir, Gadegone, sir, you are right that there is a good terminology, functional malunion. Yes.
Yes.
Good terminology.
Mukhi sir. Mukhi sir.
Yeah.
Is there any correlation between the inferior radioulnar joint pain and the functional malunion?
The Indian patients are very much adaptable to that. The function-wise disappears.
In distal and radius, some patients after collapse are not painful, and some are painful, and some are very painful. So that is very difficult to decide. That is very difficult to decide.
How to explain this thing?
No, there is
Tanna sir
always,
wants to say something.
there is always a point of ulnar collateral ligament where there is a tenderness or pain in a full supination, and literature says you have to wait for 8 months to recover that. And many times I give local injection there. If after 4 or 5 months patient is not happy, you just give local injection at the ulnar styloid process, and somehow the patient feels better.
Tanna sir, on those risks which are painful and not painful after collapse, it's
an enigma.
I have presented myself. The collapse occurred, and still the wrist is collapsed. This is the wrist. Still the wrist is collapsed. The pain is not occurring because of the collapse. It's only the ulnar which goes distally. And when the ulnar goes distally and hits the carpal bone, so I had a malunion. I was playing golf, everything was perfect, but slowly the ulnar started hitting the carpal, and then I started having pain. And the only treatment which was done was shortening of the ulnar, so that it doesn't hit the malunion. It doesn't hit the carpal. And still my non-union is there. The shortening of the ulnar which is done, it is all what you need is that carpal bone which is hitting. All what you need is you just put the ulnar slightly away and the pain goes away.
Thank you so much. So I think, Phadke sir, you wanted to say?
Yeah. My one more observation is younger patients tend to have more problems if there is a radioulnar variance. Whereas the older patients who don't have such a lot of heavy work, they tolerate that variance very easily. So in younger patients especially, I tend to advise surgery more frequently than in the older patients.
May I ask one question?
Yeah, please go ahead.
To Dr. Tanna, he had put one of the last slides in his lecture that lateral third is usually not conserved. So extreme lateral and clavicle, what is his preference nowadays? What is his preference for fixation? All those arthroscopies walas, they make us feel very inferior.
No, I think if at all, it is the new locking plate where 2 or 3 screws you can put it there.
Hook plate.
No, not the hook plate. Hook plate I have given it up.
Discarded.
A hook plate which goes underneath it up. I don't use it because it creates a lot of problems. So I'm talking about the plate which has got a...
the 6 holes, 2.4, yeah, lateral end plate.
And if it is a displaced lower end of the radius, I mean, quite often you will need some stitching of the corticoclavicular ligament.
Sir,
porcelain tape.
Sir, एक second. I had been using hook plate for many years and I developed an inferiority complex कि जरा बरोबर इलाज नहीं करता है क्योंकि अपने को वो सब सेमिटी और वो लगाता नहीं आता है. There is a beautiful 1.5 hour video put up by AO, acromioclavicular dislocations, Marty's, and one British chap is there. Lovely, everybody should, it's free, available on AO sites. And everybody should see it. And last year academy meeting, I was there in that symposium. So Mackey was conducting that. Mackey is the guy who has done a lot of things and published on acromioclavicular. And when I confronted him, hum to khada ho gaya sab, hum karta hai. So he did not condemn it. It's not true that is bad. It's is absolutely justifiable if done properly. And 99% of my hook plates have not been removed, though they come with other patient or for some other reason. So it's how you do it, and everybody should see that 1.5 hour AO video. It's a lovely anatomical dissection, and he is not trying to sell his plate. It's very, very impressive.
देखिए सर, हर सर्जरी का यही हाल है, अच्छा करो तो रिजल्ट अच्छा ही आता है.
बिल्कुल सही बोला आपने. And Mackey did not dump it. He said that I still use it.
Okay.
So please do see that video.
Yeah.
I was extremely happy after seeing that.
Yes, sir.
AO is not bad. The performing surgeon is bad. Therefore, there are so many complications. The things are always good.
Indication also should be good.
Good.
On that note, I think that was a wonderful webinar and discussion. So we had a great discussion on conservative care. And Ashok, we must thank you for allowing us to exceed our time. Thank you so much. Yeah, that was wonderful. And everyone and every faculty member still present, all still.
And sir, is it available later on also on OrthoTV?
Yes, it would be available. It would be there. It would be there.
It's extremely useful for PG.
Yeah. Ashok, thank you so much.
Chandak sir.
Yeah, please, Gadigone sir.
We should have a case-based conservative treatment. So ask all faculties to preserve the cases of conservative management. So that we can have a wonderful webinar on again conservative management once again.
Yes, sir. We'll ask them lower limb conservative. We can keep our cases conserved. Most of the time we conserve on our laptop our operative cases. Now we'll conserve on the laptop our conservative cases as well. And on that note, we thank all the faculty members. That was wonderful discussion. All of you spared
Thank you very much.
Thank you so much. Thank you, Ashok.
Okay.
Thank you.
Thank you.
Thank you. Thank you.